I propose that we now go into public session. Is that agreed? Agreed. The purpose of this morning's meeting is to receive an update on the National Paediatric Hospital project, including the new Children's Hospital at St James's and the development of urgent care centres at Donnelly and Tala hospitals. On behalf of the committee, I would like to welcome to our meeting this morning from the National Paediatric Hospital Development Board, Mr Fred Barry, Chairperson, joined by Dr Emma Curtis, Medical Director. From the Children's Health Ireland, Professor James Brown, Chairperson, and Ms Eilish Hardiman, Chief Executive. From the Department of Health, Ms Tracy Conroy, Assistant Secretary, Acute Care Division, and Mr Colm Desmond, Assistant Secretary, Finance and Evaluation Division. And finally, from the HSE, Mr Dean Sullivan, Deputy Director General Strategy, and Mr Jim Curran, Head of Estates. Good morning. I wish to draw to your attention the fact that by virtue of Section 17(2)(l) of the Defamation Act 2009, witnesses are protected by absolute privilege in respect of their evidence to this committee. However, if you are directed by the committee to cease giving evidence in relation to a particular matter and you continue to do so, you are entitled thereafter only to qualified privilege in respect of your evidence. You are directed that only evidence connected with the subject matter of these proceedings is to be given, and you are asked to respect the parliamentary practice to the effect that, where possible, you should not criticise or make charges against any person, persons or entity by name or in such a way as to make him or her identifiable. I also wish to advise that any opening statements that you have made to the committee may be published on the committee's website after the meeting. Members are reminded of the long-standing parliamentary practice to the effect that they should not comment on, criticise or make charges against a person outside of the Houses or an official either by name or in such a way as to make him or her identifiable. Can I now ask Mr Fred Barry to make his opening statement? Thank you.
Thank you, Chairman. Dear Chair, members of the committee, thank you for inviting us here this morning to update you on the progress of the work being carried out at the new Children's Hospital. I am joined here today by Dr Emma Curtis, who is the Medical Director of the National Paediatric Hospital Development Board. By way of background, the National Paediatric Hospital Development Board was appointed in August 2013 to design, build and equip a new children's hospital. A planning application was lodged in August 2015 and On Board Penola granted planning permission in April 2016 for the new Children's Hospital, the paediatric outpatients and urgent care centres at Donnelly and at Tala hospitals and related developments, including the Children's Research and Innovation Centre and a family accommodation unit adjacent to the new hospital. If I may start with developments relating to the Development Board itself, you may recall that my last appearance in front of the committee was preliminary to my appointment as the new chairman. The Minister for Health subsequently confirmed my appointment. 2 board members have since resigned, having given great service for 6 years. The appointment of new members is within the remit of the Minister of Health, and we are working together to fill these positions. There have also been resignations by executive personnel, including the project director. An open competition is underway for a new Chief Officer, and an interim Chief Officer and an interim Project Director have been appointed in the meantime. In relation to the project, the Paediatric Outpatient and Urgent Care Centre at Donnelly is the most advanced element of the work. Construction work is now substantially complete, and the building was handed over to Children's Health Ireland in May of this year. Services will commence in the new building once the usual commissioning activities are completed. This will be a very significant milestone in the delivery of suitable treatment centres for our children. Good progress has also been made on the new Paediatric Outpatient and Urgent Care Centre at Tala. The decant works are already complete and the new creche, changing facilities and offices are open. Construction of the foundations for the Paediatric Outpatient and Urgent Care Centre building itself started earlier this year, and the new building has reached first floor level. The new Children's Hospital on the St James's site is by far the biggest element of the project. The committee will be very aware that the construction costs for these works, as finally agreed with the main contractor BAM, are considerably higher than the previously estimated costs. Notwithstanding the difficulties in reaching agreement with BAM, the view of the Development Board was that it was better to proceed with BAM rather than stop the project and re-tender the main construction works. We could have re-tendered the contract, but it would have added years of delay, and between tendering costs, inflation, increased owners' costs and mobilisation costs, the likelihood was that re-tendering would ultimately result in higher project costs rather than lower. Accordingly, the Board recommended to the relevant stakeholders that the construction should proceed on the basis agreed with the main contractor, BAM. The Government authorised the Development Board to proceed with the main construction works at the end of last year. Another significant development is that it has been decided to procure employer-supplied health technology equipment through traditional procurement means rather than a managed equipment service. This decision is timely in that it allows competitive tendering, procurement and delivery of this equipment in line with the overall programme. The construction focus for the last year or so has been on heavy civil works, excavating the site, pile driving and so on, and the building frame is now under construction. This frame can be seen above ground level in places, and as it rises, it will give a real sense of the scale of the works. And the mechanical and electrical installation work has started in the basement. The next construction milestone will be when the completion of the new access road loop around the site perimeter, allowing the excavation of the strip road currently running east-west through the building site. This will be visible later this year. Drone footage from the site taken at the end of May can be viewed via a link, World Wide Web, newchildren'shospital.ie/campus.vision/dronage footage of the NCH site, May 2019. I appreciate I rattled the last bit out, Chairman. I'll be happy to give the linkage to anybody who wants it. Thank you for your attention, Chairman and committee members.
Thank you, Mr. Barry. And now can I invite Ms. Eilish Hardiman to make your opening statement. Thank you.
Thank you, Chairman and Deputies. Good morning. Thank you for inviting Children's Health Ireland to attend your committee to update you on the new Children's Hospital. I am joined today by Professor Jim Brown, Chairman of the Children's Health Ireland Board. I welcome the opportunity to provide this committee with an update on the new Children's Hospital project as requested in your invitation. Children's Health Ireland is client to the Development Board on this project, so my update to the committee is in accordance with this remit. As you are aware, Children's Health Ireland commenced on the 1st of January in 2019 as the entity that governs and delivers acute paediatric services, currently at Crumlin, Temple Street and Tala, and from July at Connolly Hospital in Blanchardstown. This commencement was facilitated by the support of the previous boards and management of our Ladies Children's Hospital in Crumlin and Temple Street Children's University Hospital, both boards which have now been dissolved. I would like to take this opportunity to thank these two former boards and the existing board of Tala University Hospital for their many years of stewardship of acute paediatric services, actually some over decades and in some cases over centuries. I would also like to acknowledge the previous Children's Hospital Group Board in getting Children's Health Ireland commenced. I'd like to point out that all of these board members are voluntary and do so with the greatest of dedication and effort. In terms of the delivery of the physical buildings, as reported to you, the Children's Health Ireland continues to work closely with the Development Board on matters relating to the build, design and equipping of the new facilities. A series of management and working groups engage on a monthly basis to progress all matters related to ensuring that the paediatric outpatient and urgent care centres at Connolly and Tala and the new Children's Hospital meet clinical and operational needs for children, their families and our staff. I would like to take this opportunity to recognise the commitment and work and support of my former colleague John Pollock, the former Project Director to the Development Board. Within a matter of weeks, we will be delivering a service at the Paediatric Outpatient Urgent Care Centre at Children's Health Ireland at Connolly. And this will be followed next year by Paediatric Outpatient Urgent Care Centre at Children's Health Ireland at Tala. These new facilities, together with the opening of the Children's Hospital in 2023, will transform how acute paediatric healthcare service is delivered to the sickest children in Ireland and how local secondary care can be delivered to the Greater Dublin area. And this is about delivering better healthcare outcomes as well as better experiences for our children, families and staff. Now, focusing on the new services. Children's Health Ireland at Connolly in Blanchardstown, the building was handed over from the Development Board to us for clinical commissioning in May. Equipment installation is near completion and hope to have that done next week. And now operational and clinical commissioning is currently underway in time for opening at the end of July, on the 31st of July, and initially on a staged basis. Just to remind the committee that 25% of our population are children under 18 years of age. The majority are healthy, which is good, but 1/4 of 3-year-olds are obese. 16% of our children have a chronic disease, such as diabetes, allergies and asthma, and this is increasing. And 2% are acutely ill or have very complex needs. Currently, there is an over-reliance on hospital-based inpatient care, with many services accommodated in facilities in Dublin that are no longer fit for purpose. The new Children's Hospital will provide national paediatric tertiary services, about 1/4 of what we do, as well as secondary paediatric care for children in the Greater Dublin area. Currently, there are 442 beds with 3,388 whole-time equivalent staff delivering services annually to 25,000 inpatients, 28,700 day cases, over 145,000 outpatients and 120,000 emergency department attendants at the 3 children's hospitals. All national paediatric services are under the remit of Children's Health Ireland, some with an all-island remit, for example, our all-island congenital heart disease services. The plan for children's healthcare, as outlined in the Integrated Programme for Child Health, includes acute paediatrics, social, community, primary and child and adolescent mental health services. This cross-divisional programme rightly reflects a population-focused, integrated and interdisciplinary approach to children's healthcare and identifies the resources required to best support parents, guardians, families, children and young people in achieving healthier outcomes. From a Children's Health Ireland perspective, we have been focusing on our integration programme, and that's on valuing and aligning the different cultures from the 3 hospitals, integrating our IT systems, standardising our clinical and operational protocols, staff recruitment and training. There is significant work underway across Children's Health Ireland, and I would like to take the opportunity to update you just on some of these. We've implemented a single patient administration system. So part of the Children's Health Ireland path to integrating our ICTs is a new patient administration system that was implemented and went live in mid-April at Crumlin and Temple Street Children's Hospitals, I might add, without any disruption to services. It will allow Children's Health Ireland healthcare professionals working in both of these hospitals and in Connolly when it opens to view the shared patient details, including inpatient and outpatient history, referrals, waiting list details, transfers and chart tracking. This means patients will have a single Children's Health Ireland unique identifier across Crumlin, Temple Street and Connolly when open. Is a very tangible and valuable result of the early part of our integration work to support shared and common outpatient waiting lists, starting with our general paediatrics. In relation to staffing, the majority of recruitment in for the Paediatric Outpatient Urgent Care Centre at Connolly is well advanced, with most of the doctors, nurses, health and social care professionals and administrative staff now recruited and have start dates over the coming weeks and months. And we will start to treat patients from the 31st of July. Children's Health Ireland at Connolly in Blanchetown will provide a range of services that include urgent care with short stay observation unit, where children are observed and treated for up to 8 hours before being discharged, with a very small number requiring admission to one of our hospitals. It will also have outpatient care, which includes general paediatrics and orthopaedic fracture clinics, and other specialties will follow. When open, Children's Health Ireland at Connolly and Blanchetown will create an additional capacity for general paediatrics, which is very welcome to address our waiting lists and will contribute to the significant reduction in these and make it better for our children and families. Children's Health Ireland at Connolly and Blanchetown represents a significant transformation of services for families and children. It will facilitate a new model of care for paediatric services in North County Dublin and its environments, which it doesn't have at present, and delivering the right care in the right time in the right facility, as close to the child's home as possible, as outlined in Sláinte Care. I would welcome the opportunity to invite and bring members of the committee to visit the centre ahead of its opening for clinical care, so that you can see at first hand the new state-of-the-art facilities and the impact that it will have on delivering care and services. In conclusion, Children's Health Ireland is in a period of transition, not only for our staff who transitioned to the new entity in 2019, but in terms of how acute paediatric services are delivered in Ireland. We believe that the changes we are making and the impact it will have can be used as an exemplar for transforming services across the system. The changes that we are making will deliver better, safer and more sustainable healthcare to our children and young people and their families, and better for our staff for future generations to come. I thank the members of the committee for their attention, and I'm happy to take any questions you may have.
Thank you very much, Ms Hardy. Now we're going to open the meeting to our members, and our first contributor is Deputy Stephen Donnelly.
Thanks, Chair. Thank you all very much. You're all very welcome here today, and thank you for the updates. Ms Hardiman, could I start with Children's Health Ireland? Thank you for the information you've given. I just would like your steer on capacity. Obviously, we're all very acutely aware of some of the waiting times for sick children, for some very sick children, in terms of getting access to diagnostics, getting access to consultant assessments, getting access to surgery where necessary. When the reconfiguration is done, so when the existing 3 children's hospitals are shut down and we have the new children's hospital with the satellites, you said that we currently have across the 3 hospitals 442 beds. What will the total number of beds be when the reconfiguration is complete?
The total number is beds that are accounted for according to using the definition will be 473. But in addition to that, there will be 24 short stay beds that are in the emergency department and the urgent care centres. Because they're not formally admitted to, they're currently being admitted into the hospitals. Yeah. So we don't count them, but so the capacity increase is 31 new beds, but also 24 short-term beds to deal with, and that's the new model of care.
That 31, they're inpatient acute beds?
Inpatient and day cases, and where the biggest changes we'll have in compared to the current capacity.
Sorry, just in terms of the inpatient beds.
Yes, inpatient, yeah. 31.
There'll be an extra 31. Yeah. Thanks. Can I ask on the staff? There's a very big complement of staff. You mentioned 3,388. Could you just tell the committee, could you break that down a little in terms of clinical, administrative, management and so forth? How many clinicians are in that 3,388?
Well, I have some details here I can look up for you, but the vast majority of them are clinicians.
The vast majority of 3,388. Okay. Is that across the country? Is it in the Greater Dublin area? Where is that?
No, they're just the 3 children's hospitals
that we have at the moment,
which are in Children's Health Ireland. We have the 3,388, and we have a plan to go to your 3,700 actually in the new Children's Hospital. We have phased that plan over the next few years because it is a challenge. We would say that with workforce is a challenge within healthcare, and we have outlined a demand and capacity plan, particularly a supply and demand capacity, particularly for nursing, because that is our greatest workforce actually, and the largest numbers actually are in nursing.
And so that's quite an increase. That's an increase of say 312.
Well, it's 10%. It's 10% increase in what we have.
Can I ask, how much of a reduction are you foreseeing in administrative and management staff due to the reconfiguration?
Yeah, one of the things we identified is that with the moving to a digital hospital is you'd actually transform particularly some of the transactional practices. That actually requires implementation of some of the national IT programs, particularly around finance and logistics. Yeah. So we have already started that process with not having storerooms, for example, at Crumlin. We introduced...
No, I understand that, which is why I'm asking the question, what is the reduction that you're foreseeing?
Yeah, I can actually go and just check it, but we have identified through ICT programs that we'll be introducing to remove some of the transactional processes and actually replace them with more what we call higher value add, particularly client facing and patient facing services.
Great. Could you give us those figures? That'd be great. Thanks. I might just, while you take the time, I might just, Mr. Barry, if I might ask, I might ask you, Ms. Hardiman, just while you're looking, there's 2 questions, so just give you the time to look at them. As we move up to 3,700, it's good to see this projected increase in staff capacity. Really, the 2 questions I'm interested in are, what is the projected increase in clinical staff? And I presume, but you might clarify, I presume there will be a commensurate reduction in administrative and management staff as we move from 3 hospitals to 1. So really it's how is all that playing out in the move to 3,700. Mr. Barry, I hope it's all going well. Last time we met you were just being appointed. You said in your opening statement that 2 other members of the board had resigned. Are you in a position to share with us who they are?
Yes, I am. They're John Morton and Margaret Sayers.
Okay, thank you for that. You also referenced that additional executive personnel had resigned.
Yes.
Could you say a bit more about that? Is it many people? Was it voluntary, or did you, as the new chair, suggest maybe that some people needed to leave?
No, the departures were all voluntary. And it isn't that such a large number of people have left, because the numbers are quite modest, but the project director left and the construction director left and another project manager within the team left, so they're quite senior departures.
Okay. And given the scale of the overspend and the detail we now know about the various management failures and so forth that led to this huge overspend, one of the things we discussed before, your sense was that the team was probably missing some skills. Have you brought in new people, and could you just say a bit about what additional skills you've brought into the team to make sure that these kind of overspends don't happen again?
Indeed. The first, I suppose, very major step was to recognise that we had asked our project director to also act as chief officer, and in my view and on the view of the board now, that was too much to place on one individual. So we've separated the positions, and we have a chief officer. We have an interim chief officer at the moment, with a competition underway for a permanent chief officer, and we have a separate project director position. So that's quite an important strengthening at the top level of the organisation.
Okay. Thank you. Can I ask you, you mentioned the managed equipment service.
Yes.
Clinicians I've spoken to are very worried about this, about the fact that this is being dropped. The point they've made is that around the world it is best practice to have managed equipment services. So, for example, in our children's hospitals in Dublin at the moment, some of the most important diagnostics machines, like the MRI machines, were meant to be decommissioned years ago. The magnets, for example, are way beyond their use. And that we're in a situation right now that if, and I'm told when, these machines go, there's no replacement for this, and it's a very high-risk way of running a health system. And that the solution to this that is used in other countries and that was meant to be used in the children's hospital was the managed equipment contract. So in other words, our children are being diagnosed using, and our clinicians are using, the most up-to-date equipment that gets refreshed, that gets renewed, so that the best possible technology in medical care can be advanced. Now, I appreciate there might be a cost saving in moving back to the old way of working, but is it not a case that this introduces a significant medical risk, and that actually what we're ending up with is the worst conceivable situation, is because we've paid so much money for a fancy building that may be beautiful, I hope it is, but that is, due to the design of it, is very, very expensive. And as a result, what we're actually cutting down on is the actual medical services provided in that building, which really is the whole point.
Sure. Well, I'll pass some of the answer over to my colleague, but I would say just the medical equipment that will be provided, through a direct purchase, will be the medical equipment that's required. There is no reduction in the specification of the equipment that's going into the hospital for this decision. So it shouldn't be thought that this is being done to save money up front. If anything, it probably increases the expenditure up front. And the situation in hospitals with equipment becoming redundant and needing to be replaced is replicated, throughout industry everywhere. And really, whether or not equipment is replaced down the road is a matter of whether the funding is made available to do so.
I think
it's not predicated by a decision that's made at this stage.
I think that's exactly the point, though. The experience of our clinicians in the Irish healthcare system is that the ongoing investment is not made. And so a piece of very fancy equipment is bought and it's not maintained. And that the way of dealing with this, and therefore securing a higher quality healthcare service, was to move to the managed equipment service, whereby that investment is locked into the contract.
Sure, I understand that.
Okay. Can I ask you finally, and then we might go back to Ms. Hardiman. One of the areas that I've asked you about before is cost savings. Obviously, there are serious implications to the healthcare system and to other sectors of this huge overrun. Indeed, moving away from a better way of making sure the diagnostics equipment is up to speed is one of these. I think we're sacrificing the medical care in the building because of the overrun involved in the building itself. Now, the last time you were with us, you suggested that the best way to manage the risks and the costs was to look at minimising further additional overspends. But you were new in, so I really just wanted to ask you the question one more time, which is when a member of the public who ultimately is paying for this hospital looks at the hospital, they see a very beautiful glass donut, curved in every conceivable way. And none of us live in houses that are curved glass donuts. And indeed, no private sector company, to the best of my knowledge, builds their buildings as beautiful curved glass donuts. Why? Because it's not a good way to maximise the space available to you, and because glass and curves and all of these things are about the most expensive way you can go about building buildings. Have you had time to reflect and think, do you know what, actually, the design of this building, the approach to this building is incredibly expensive. The architecture involved means that there's massive capital expenditure needed that actually other buildings don't require, and there are opportunities to make some changes here that really could drive down the costs and do things like make sure we have the right money going into the medical services like the equipment.
Fortunately or unfortunately, the project is so advanced that to do something like change the facade and revisit the materials or even the architectural style would mean effectively stopping the project for a couple of years and starting again. It would involve going through the whole planning process. It would mean stopping the construction works. You know, for example, the facade you mentioned, that's on order. The main contractor has placed orders. It's being fabricated at the moment. So we're beyond the point where examination and change of that sort can bring any reduction in costs. Now, that doesn't mean there aren't possibilities to make some changes that will reduce costs, and those are being made at the moment. The engineers and the architects are going through the design with the fine-tooth comb, and where small changes can be made that don't affect functionality and that wouldn't put us in infringement of the planning conditions, where those can be made, then those changes are being made. But I think I may have said before, I'm not sure if it was at this meeting or not, the savings that will come out of that, whilst they're significant in any personal terms, they won't be significant in the context of the overall cost of the project. We're too far down the road to do anything like that.
Can I ask, given your considerable experience in construction and major construction projects, is it the case that this design, the curves and I'm not blaming the architects work to a brief, but that this is essentially a very, very expensive design for us to be engaged in?
Well, you know, firstly, I would say that I haven't looked backwards, and I've been asked, you know, many times what I think of the PwC's view of what has happened to date and everything. My focus, and I've been fairly busy with it, has been on what's going on today and on the organisation going forward. So I haven't done the sort of review you're thinking of. Yeah. I would say that as I sort of travel around the world, I see that public buildings generally tend to be a little bit more than just purely functional buildings. And perhaps there may be a touch of that in this building as well. Now, whether that's right or wrong, that'll be for future generations, I suppose, to decide as they look at it.
Taxpayers today, but thank you. Chair, I'm happy to, I'd like to go back to Ms Hardiman, but I'm happy to stop and come back on the next round if that...
We'll give you the opportunity to finish your question with Eilish Hardiman, yep.
Yeah, okay. Can you go through the figures?
So I'm just starting them up here. So what we have is in relation to the vast majority of the increases actually are around clinical staff. So we are looking at our medical staff, which is our consultants and our non-consultant hospital doctors, of an increase of 124 over the next 4 years. I can report that as of this year we have 18, for example, new NCHDs recruited, and we have 17 new consultants recruited, which is good. So we have phased those over the next 4 years. In relation to the nurses, it's 250 additional nurses. We are cognizant that, you know, we don't stay static. That does require, we have turnover in the children's hospitals of about 10%. So we are actually have a plan of how do we phase that up, taking the current churn rate into account, as well as looking for the new posts. And some of these posts are in different posts like nurse specialists and advanced nurse practitioners. So it's not just replacing them with actually new staff nurses. In relating to our health and social care professionals, there's about 200 of those that actually need to increase. These are obviously physiotherapists, health and social care, or the occupational therapists, psychologists in particular, because the services which are in, which are for children, which needs a different amount of support. And again, the investment into Connolly, most of the new staff there are in those type of services because that's where the deficits are actually in general paediatrics. In relation to the non-clinical, so this is like the technical services and all of those supports, and the administrative, the vision for the hospital actually is a digital hospital. A digital hospital then doesn't require a medical records department. So our biggest change is going to be in the 3 children's hospitals. We currently have about 140 people involved in processing paper. So we're moving to whereby we will be changing those roles, so they're no longer doing administrative type of roles, but into converting them into more patient-centred client filling roles. And that is about a reduction of 140 staff that will change their roles from currently.
It's not a reduction though, is it? It's a transition. I guess the question I'm asking, my fear is that you were going to say something like you've just said, right? Because when you combine 3 hospitals into one, there are huge opportunities to
Well, I haven't answered that part.
To rationalise.
I haven't answered that part.
Okay, sorry.
Okay. Because there's an integration project, a corporate integration project. So we're looking at all of our corporate functions, for example, like finance, HR, ICT, quality and safety. And we have a plan of how we're going to merge those, looking at the existing roles to where we don't have 3 of everything, but moving to whereby we have 1 of some of the posts. Now, naturally, we're moving from smaller to a bigger organisation, so we still need some of the posts to take on broader remits, but we are actually looking at streamlining, and that's why one of the reasons to why we sought to be commenced 4 years out, so that we actually work through a process over the next 4 years of merging those corporates into one single functions and look at what we can do in relation to streamlining those.
So what's the number?
We haven't come up with a number. We know what our facts are at the moment, and we have a plan to actually identify it over this year and next year of merging those, and we're looking at streamlining and not replacing posts. So we're starting that process at the moment and getting other individuals then to take a broader remit across CHI as opposed to just in their single hospital at the moment.
Okay.
So I can give further details. I mean, I can come back.
If you wouldn't mind, it worries me because you're able to give very useful and very exact information on doctors, nurses, and healthcare professionals when we're hiring people, when it's good news. But when we ask the harder question, which is, well, where are we going to rationalise the services? Suddenly, what I'm hearing is 2 things. One, we have no numbers, and secondly, actually, where technology is making redundant entire areas, we're going to find other jobs for them to do, and that there's nothing to do with the people involved, but that's the kind of thing that has gone on in the healthcare system for a long time, which ends up with a ratio of an awful lot of administrators to not enough clinicians.
Well, I can assure you that the vast majority of the services in the Children's Hospital are clinically based. That is without a doubt. But one of the things that we're looking at is, because we're co-locating on the campus with St James's as well, we're looking at that from a campus perspective. So we are looking at shared services with St James's, which is really important. So, for example, there is only going to be 1 distribution centre for the whole of the campus. So when we're looking at it, it's broader than just the Children's Health Ireland. So we're trying to look at rationally with St James's to see how can we combine all of those support services into 1 distribution hub, and actually, so that's our plan. And it does take it's tricky, and it does require negotiations, and it does require careful planning. And what we started then is with, because the non-value adding elements is having like warehouses and that on our campus. So we've already started with putting in the central distribution services, for example, at Crumlin. We're going to move that into Temple Street, and then James's are going to move it together, so that when we move to the campus, we don't have things like warehouses, which are not value adding to actually where we need most of the focus been on the clinical services as opposed to those support services. So we have a plan to optimise those, but they do require us working with the HSE on the plans for modernising the whole of the health system around how it supports those transactional processes and back of house support for health systems.
Thank you. Thank you, Chair.
Thank you, Deputy Donnelly. Now we're going to move to our Fine Gael members. Deputy Durkan.
Thank you, Mr. Chairman, and I welcome our witness this morning. Thank them for their information. Just to go back to something, I think Mr. Barry mentioned at the beginning that the cost of the Children's Hospital is higher than previously estimated. Now, my colleague here was quite innovative in his generation of expenditure as opposed to estimated expenditure. What are we talking about at the present time? Have we overspent on the works to date involved? In A, the two outreach hospitals, the acute care in Tala and in Blanchardstown, have we overspent on the works already carried out at the site of the new Children's Hospital? And to what extent have we overspent on that? Because the word overspend keeps coming again, which is quite damaging to the morale of the project, for want of a better description.
And thank you indeed for the opportunity to clarify what I said. The increase I was referring to was the historical increase that brought us to the government approval of last December. There has been no overrun or overspend since that time. So the current works are within the budget approved by the government last year. All
of the works in all the sites are all within budget so far?
Yes, it's a single budget, but yes.
So the word overspend is actually wrong.
Well, I was referring to the fact that some years ago...
Under projection or underestimate?
Yes, there was an underestimate some years ago.
And how did that develop into what is now commonly referred to as an outrageous overspend? Which when the general public can wake up in the morning, read the newspapers and say, this is appalling stuff. There's no overspend at all. All the monies, all the works involved so far are within budget. Is that true?
Yes, indeed, it is. The original problem and difficulty arose from an underestimate of what it would cost and indeed needed to cost to build the hospital as it is configured. And of course, it took some time for a realisation to dawn that that estimate had been too low.
No, my colleague was very inspirational again in this. He mentioned that clinicians had expressed some concerns in relation to procurement, and I can understand how, having been involved in the initial stages of the hospital development programme in the past, the clinicians usually want the best, and I'm quite entitled to that, and they should get the best. But it also, I'm not sure whether my colleague was suggesting increased expenditure in order to comply with the wishes of the clinicians, or whether the quality and status of the services likely to be provided is likely to be less or of a lesser value as a result of what the clinicians have expressed and they are concerned.
No, just to confirm on that, the specification for the equipment in question has been agreed with Children's Hospital Ireland and the clinical personnel involved, and whether we were to procure that equipment through direct purchase or through a managed service is a contractual matter. It has no impact on the quality of the equipment. The equipment will be provided as agreed and required.
I'm very impressed with the response, and I'm great to have an opportunity of reassuring my colleague as well, who had deep-rooted concerns about the whole project coming asunder once again. But obviously that's not the case. All provisions have been made. Adequate provision is being made for the ongoing procurement as required.
Correct.
And to the standard and quality required.
Correct.
No, my colleague is saying no here, but that's a stage whisper. That's just he gets into the habit of doing that from time to time, Chairman. I want to mention as well, incidentally, since overspend has become a huge issue in terms of public confidence in this system, it is important that we clarify that once and for all. So we now know that there is no overspend. It took all this time to bring out that kernel of information, but at least we have it now. I want to mention also. Ms. Hardiman mentioned about chronic diseases in children. Can I ask how best we should handle this, manage it as and from now? Obesity is mentioned, diabetics have been mentioned, so on and so forth. There's a need, to my mind, for a plan, a master plan, to deal with this situation as it emerges before it becomes an absolute emergency. So could I ask for some clarification on that, please?
Certainly I start, and my colleague Dr McCurtis might want to chip in. I think it's important to note that there is a national model of care for paediatric health care. That national model of care sets out kind of the grand scheme plan for 25% of the citizens of Ireland. It is an integrated plan, which means that it takes into account community as well as acute services, because we have got to work in an integrated way, which I know the committee supports and has been outlined in Sláinte Care. And in that plan, we have identified over the next 5 years what are the priority issues that help address the challenges that are facing children's health care. That does involve us working collaboratively with our colleagues in the community, GPs, public health nurses and others, to actually look at the implementing Healthy Ireland and other plans that have a significant element of focusing on children. The government also has, the first 5 years. It's a very important plan that actually identifies that in getting a child started in the right direction around their health and healthcare outcomes has significant benefits to the adult system and to the health and wealth of a country into the future. So there is lots of planning and lots of integration work, and there's a great collaboration amongst the paediatrics and I would say with community and the acute system working together on what are the priorities, because we know everything can't be invested in the first year. So we've identified collectively the priority areas that we need to focus on. And we are working with some of the national leads in relation to the plans to roll this out. So from our perspective, we this year have identified that the regional units in Cork, Limerick and Galway in particular, they have got, I think, almost 5 million investment, just to build services there, so that we're working in a way where that the new children's hospital, it's about a network of services as opposed to just one bricks and mortar building, and that we work collaboratively with our colleagues in these services to ensure as many of the services as possible are delivered locally, and some of our clinicians will go down and do outreach clinics in these regional hospitals in specific areas that we've all agreed. And we're looking at every year over the next, it's really as a 10-year plan, over the next 5 years in particular for the Children's Hospital, is how can we invest in whereby we're adding to the existing resources that we have in children's healthcare, but to work in a more integrated way with our colleagues between community, mental health and the acutes in particular, around changing maybe how we deliver services to get a better outcome. I'm glad to report that, and I think Emma will concur, that obesity has started to plateau. So there are some positive signs around that. Unfortunately, the chronic diseases are still on the increase. I'm also glad we've getting our second allergist starting with us, which is important, and dermatologists. And these are all the areas that we have the chronic diseases and rheumatologists. These are new investments that have been made this year into Children's Health Ireland that I think will transform how we're addressing some of those chronic areas. And in particular, the plan is, not to get down to more super specialties. We definitely have a need requirement for some of them. But the plan is within the acute system to build a very strong bedrock and foundation of general paediatrics, and then to support them with these tertiary specialty services. So we are glad to say that our increase in general paediatricians, that we have 6 new ones that have joined us, and that's to the whole team in CHI. And already they are bringing in expertise around adolescence care and transition care and general paediatricians with a special interest in dermatology, and doing things a bit different, whereby the GPs don't have to wait to go to the specialist, which have some long waiting lists, but our general paediatricians are taking on board those referrals on a single waiting list, jointly shared across Children's Health Ireland, whoever has the next available clinic. So it's about more efficient use to our existing services. And we're working with our colleagues to try and triage as what should go to the specialist and better use their time, and what can and should be managed with our general paediatricians, and using them, engaging much more closely with our general our GPs in the community about managing those chronic diseases in that way. So it's about supporting them to work a bit differently. All the things that I've mentioned in Sláinte Care are the new ways of working that we're embedding into the Paediatric Outpatient Urgent Care Centre at Connolly. And if I may continue, so for example, there's clinical triage of referrals. So our GPs, our general paediatricians are doing a clinical triage clinic where they will clinically triage the referrals. They will phone the GP, because that is really important, and they have managed to divert 30% of some of those referrals by actually engaging with their GP and supporting them to actually care for that child with their GP, as opposed to having to come in for actually referral. We're bringing in clinical nurse specialists in general paediatrics, again, who can deal with some of the chronic elements in paediatrics, like constipation and some of the rashes and issues like that, where they're able to work with those families as opposed to them having to see a consultant. So all of these new ways of working are how we're trying to transform the services, and the new facilities at Connolly and Blanchardstown allows that, because we haven't had paediatrics in North County Dublin and its environs. And I'm glad to report that the GPs and our community colleagues in CHO 9 in that area are looking and working with us collaboratively to try and use this new opportunity to try and transform and not just do the same old, but implement new ways of working, particularly about managing chronic disease as much as possible in the community. But maybe Emma might like to add to that.
Thank you. Thank you very much. I think looking at the chronic diseases, there's probably best to look at it in two different categories. So to a certain extent, we have an increasing number of children with chronic and complex disease because we have got so much better at managing those conditions. So conditions that might previously have been led to the child's demise in early years, that no longer happens, which is due to great progress both in the quality of care delivered and medical science. So there is an increase in chronic disease because children are living now with chronic disease, and therefore the emphasis is not only on continued survival, but also improving the quality of care. And that's both a hospital and a community function, because those children are all over Ireland and need the support of community, physiotherapists and speech and language therapists and occupational therapists. So that's where the national model of care comes in, is making sure that children receive both the specialist medical care they need, but also the community clinical care they need in order to enhance the quality of life. There's another bit, I suppose, that's interesting, is that diseases like diabetes, the rheumatoid disorders, many of the epilepsies now, with advances in the understanding of genetics, a lot of these conditions seem to be genetically determined. So there's a big cohort of children now where we're understanding their chronic conditions, we're understanding where they come from, and also this gives you a lever of improving treatment. So these are conditions that are inherent to the person, and therefore not related to lifestyle or anything like that. So I think there's the very medical component, and I think we understand why there is an increase in the number of children with complex and chronic conditions, and it's because care has improved. But we have to continue to improve it, and we really have to make sure we improve quality of life, because living with poor quality of life is not a huge improvement. The other piece, I suppose, is then something like obesity, which is really, it's a mixture. While there is a clinical medical component, there is a huge kind of multi-agency, community, multidisciplinary aspect to it. And within, for example, within the HSE, there are all of the national programmes which have made a huge difference. Within the paediatric national programme, it gave us an understanding of paediatric services around the country that we really never had before, and has enabled Children's Hospital Ireland to have a national coordinator now for this network, this national network. But the other piece that is of value from the clinical programmes is it brings all of those, within the HSE, brings all of those programmes together into kind of a super group, really looking at important public health issues, and childhood obesity and wellbeing is one of those. But that will obviously involve education, it'll involve facilities for sport and recreation, it'll involve basic nutritional advice for every mother of a young child. So that's a huge programme, and it is encouraging to see that it's more of an issue, that people are taking it, that people understand that this is something we need to address. So I think we will continue to see a growth in the complex and chronic health conditions, and hopefully through really a multi-agency involvement we might begin to address a more complicated issue like obesity, which is not just, it is a health issue because of its consequences, but its origins are much more complicated, and that really requires everybody to be involved.
And thank you, Mr. Chairman. I come to the end of that to know I don't propose to go on as long as the last speaker, Mr. Chairman, in deference to the other speakers who still have to come. But I think that's very impressive, and I think it's correct as well. I think the very fact that the agencies and bodies providing the service are fully alert to the full requirements, the extent of the demand and the likely demand. Can I ask how you identify, how it comes to the attention of children's services, medical services, that there is a requirement in the first instance? Is it the initial checks at birth or immediately after birth, or to what extent do issues arise during school medical examinations, which I have a particular interest in, or otherwise? How do you become aware of them?
I suppose increasingly now there is many of the serious chronic conditions are identified before birth. So they're identified in the maternity hospitals. So increasingly there is an awareness before a child is born. So obviously this is all documented. So services maintain databases. Where I work, we have a database which identifies the profile of, for example, I run a developmental and neurodisability clinic, so I understand what is the need that's presenting to me, and then we feed that back into the system. So, and there's a disability register, there's a cancer register, you know, there are registers that understand the need, and the data and reports from the hospitals provide information. So it really is a piece about data collection is incredibly important. The school piece is still very important. I mean, there's a very good child health surveillance programme which is delivered in the community, and then within schools an emphasis on ensuring that dental issues, hearing and vision issues are picked up in children in school, because obviously that would impact on their education if it were missed. So those services are existing and really important, and they're outside hospital and are managed through the HSE.
The point that would come to my attention, Chairman, and I hope I know the answer, is that hopefully all these services will be immediately and readily available to all children in all parts of the country simultaneously. That, in other words, we don't have a system whereby somebody in Kerry or Donegal or Wexford or something like that has to wait longer to be able to avail of the high quality of services that are available. And they will be available. So you're satisfied that that is the case?
Well, I think specifically about the new Children's Hospital, one of the intentions is that with this development of what we're calling really a foundation stone of general paediatric care, which replicates the general paediatric care that's available in all of the regional hospitals, that access to specialist care, so these are the cardiologists and the rheumatologists, that access to them is the same for everybody throughout the country. So everybody gets the same level, foundation level of secondary care wherever you live. So if you live in Dublin, you don't go straight to a specialist. You go to a secondary general paediatrician who's highly competent and will deal with the vast majority of children they see, and then everybody around the country has equal access to the specialist care. So our aim is equity of access for children throughout Ireland.
Thank you very much. One last question, Chairman. I know there are other questions that you can follow up on there at a later stage. One last, I hate, my colleague has gone missing at the moment, but one last thing in relation to construction. He seems to have a preference for right angles and squares as opposed to oval. I'm not an expert in this area, but I do have some knowledge in it. There's absolutely no difference whatsoever in the cost in a graduated curve. It's the right angle curve that creates the expense, and it is incorrect to presume that the design is wrong because it has a graduated curve. In actual fact, right angle curves inside or outside the building are the most appallingly frustrating from a builder's point of view, and all builders will tell you that straight away, even if you're only building a house. But I'm willing to give further information on that as required, Chairman.
Referring to the Pythagoras theory.
Yes, as and when.
Thank you, Deputy Durkan. Now, Senator Colm Burke.
Thank you. Thank you very much, Chairperson, and thank you indeed for your presentations here this morning. Could I just go initially to the National Children's Hospital and the progress of the project at the moment? The last time both the Chair and myself went out to visit the site, I think there were 450 people on site working there at the time, and it was explained to us that, you know, when it comes to a certain stage, obviously the numbers working on the site will have to increase substantially as regards fit out and all the necessary specialties that need to go in, from electricians to plumbers to all of that area. I'm just wondering, just in relation to the project itself at the moment, my understanding is that in any major project there's a kind of a time chart made out, and like there's certain targets by certain dates. I'm just wondering at the moment, where are we in relation to meeting those targets? Are we ahead or are we behind in those targets that are set out for it reaching a certain scale by the end of each month? The second one is in relation to accessing people to do the work. I think obviously because of the scale of this project and because you're competing with a huge number of other large commercial projects in Dublin City at the moment as regards availability of people to do the work. I'm just wondering, where are we with making sure that we do have the people to carry out the work as the project progresses? And I'm just wondering, is there any aspect at the moment of the project where concerns have arisen in relation to shortage of supply of any part of, whether it's in relation to labour skills, whether it's in relation to materials, and whether it's in relation to, you know, timescale for accessing the site? Because obviously you can, you know, with heavy traffic in that area, it's not always possible to deliver to the site when you need to. So I'm just wondering, maybe you might give us some idea of what the challenges are on that, and I'd like to see, you know, will we meet our targets, and are there concerns there at the moment that we need to be aware of?
Certainly. Well, as you know, I think, and indeed can see even driving by, a great deal of progress has been made on the main hospital construction already, and you can see the frame of the building is beginning to rise above ground level, so you can see it from the outside. Some of the work is behind the original programme, some of it isn't, and there probably isn't any one single reason for this. It's a very, very big job, and even for a very large international contractor such as BAM, getting up and running efficiently on the scale required is always difficult and can take a bit longer than anticipated. Subcontracts have to be finalised, and even though everybody knew the contract was going to be awarded and so on, there are still the further negotiations with subcontractors sometimes take a bit longer than might have been the case. Design details have to be agreed in support of the construction. And of course the construction industry, as you say, is very busy, and resourcing skilled tradesmen and construction management staff as well are hard to come by just at the moment. So there are all of these sort of challenges there. And there's the site itself. The site is very congested. Access onto the site from the outside is very difficult. It's a busy part of town. There's a lot of traffic there. That's hard. And then within the site itself, we're building everywhere on the site. And of course, everybody knew this going into the project, you know, and everybody sort of planned for it. But very often, the reality when you actually encounter it can be a bit more difficult than had been anticipated. And, you know, external factors come into play. For example, there was high windage for a period earlier in the year, and the tower cranes were out of action.
Sorry.
You know, so factors like that all play a part. But, you know, there's 3 years construction to go, and BAM, who's the main contractor, and the principal subcontractors, Mercury and Jones, they are all very large, experienced companies. And with the time in front of them, I'd say they have plenty of opportunities to mitigate any delays to date.
But there are delays in some aspects of it.
In some aspects of it, yes.
But are there delays that are causing concern to you at this stage?
Well, they are getting our attention. I mean, I wouldn't like to be alarmist about it. It's quite early in that phase of the construction. But yes, we and the builders are in constant discussion about how to mitigate this and what's to be done about it.
And in relation to, availability of materials or whatever, I mean, are there challenges in that area?
Well, materials, I suppose labour is a bigger challenge, skilled labour, than actual materials. And the site, you've been on the site, of course, and you probably have heard all the different accents and languages on the site.
Yes.
The labour on the site is coming from all around the world, and where perhaps in the last boom that we had, quite a lot of the labour came from Poland and some of the Baltic states. Those states themselves are doing very well at the moment. Their economies are strong and there isn't the same availability as from there. So more of the labour is coming from some of the other East European countries.
Okay. Just could I move on to the Connolly project? In relation to the cost of that project, has that stayed within its budget from day one?
Well, I'm not sure what the budget for this specific element was from day one, but it is within, the satellites are within, there's the 1.43 billion authorised by the government to cover all of the works. And those hospitals are part and parcel of that.
And that's completed now. It's now at fit-out stage. And we are going to be there within target of the.
We are still within the 1.43 billion.
But in relation to the actual opening,
it will be open in a matter of
weeks.
Oh, sorry, weeks. Yes.
And maybe you might outline you talked about it would be opened on a gradual basis. You might outline what's involved there.
Yeah, so just to go back to, if I may, so the facilities are outpatients, which everybody understands is a Monday to Friday, 9 to 6 facility. So that actually is opening, and we've got all of the staff ready to proceed with actually that, as with the orthopaedic fracture clinics, because they already take place in Temple Street. So we don't have any increased number of fractures. We don't anticipate more children breaking legs, but what we do is depressurising Temple Street by moving them out of very, very cramped facilities in Temple Street into the new facilities at Connolly and Blanchardstown. In relation to the urgent care, we're doing that in a staged basis, and some of this is just, it's a new building, people are getting used to it, we're testing it as much as possible, and it's our quiet period during the summertime for urgent care. We, like everywhere else, it's the winters when things get very busy. We are still have some staff coming in over the next weeks and months, so we're doing it in a staged basis, and we'll be going out and communicating, and that means the hours of opening, so we'll open them with an increasing phased basis over the next few months.
So the staff will be transferring out from Temple Street, is it?
No, just to be clear, we have, this is about one entity, and this is about staffing joining the services. So, for example, like the emergency department services and general paediatrics. So we have increased the staff in those services, and then the staff rotate or are allocated and rostered out to the services in Connolly. And this is to give because we want the public to be assured it is Children's Health Ireland staff that are there, they're not different. And it's also to ensure if the patients need to come back later into the hospitals, people understand them and they're coming back in under the same clinician. So it's about that new ways of working, trying to give a very unified, standardised services across Dublin. So starting with Connolly and then doing the same in Tala next year.
Okay. Just in relation to the other aspect of it, obviously for this whole project is, you've now 3 hospitals that are all going to come together, and about the whole computerisation now. I mean, are we actually working with the existing hospitals about having one common system, or is that already in place?
Yes, so that's part of our integration. So, again, we do and should acknowledge the commencement was a big milestone for us in our services, because that means now we're moving to single functions. So single functions of ICT. So we have identified within the existing hospitals, there's 4 kind of fundamental basic IT systems that we need to become a single instance of that ICT system across all of our sites. Patient administration system being the biggest and the most important. So that went live in April, and we had 28 million patient records transfer from Crumlin and Temple Street, all of our history, onto this new system. And that is a phenomenally successful project, and took a lot of time and effort without us actually impacting on any services. And it was a very successful transition, and with only a handful, like 0.001, that needed to be amended or adjusted. So it was a very successful project with a lot of effort from a lot of people. Our next one that we're moving is we're having a single system in our emergency departments. That's really important because the people do go around to the different emergency departments, and particularly from a child protection perspective, having the same information across on the one system across our emergency departments is a key quality and safety requirement, operational requirement for us, obviously in children's health care. And the next system we're moving on to then is we're looking at electronic documentation management. That means scanning documents. So we're on a digital journey over the next 4 years to a digital health system. So we're looking and have identified what are the existing systems that need to become single incidences, and have a planned approach to do that and implement them in Connolly, so that the staff in Connolly can see the records if the child has been to one of the other hospitals. And then we are also working on the electronic healthcare record, which is the new system that will be put into the hospital.
Okay, but just at the moment, if you have a child who's attending 2 different hospitals in Dublin now, the one hospital at the present time won't be able to access the file on the other?
No.
So,
so this is better, what we will have, than what we have at the moment. Currently, we did notice actually that children have files in the 3 different children's hospitals, and you're ending up having to phone a colleague or try and get that information or get it transferred. So this is better for the professionals that are actually delivering healthcare, where they can go in and actually look up the record of what has happened in the other hospital. They can just see it, which is very important. And then what we're doing is as much as possible, then we are putting the information up on the SIM system so everybody else can see.
When you're talking about the SIM system, when you're talking about then someone from Cork or Galway or Limerick, being, say, you have someone in Cork attending the paediatric unit in CUH, will the consultant down in the CUH be able to get access to those records? And likewise, will the person in Connolly or wherever be able to get access to the records in CUH for that child?
Yeah. That's the future vision. That's the national EHR project for the HSE. So we're not implementing that obviously within CHI. What we're doing within CHI is making sure that our staff can see our patients within CHI. That is just internal to us in the interim, in the immediate issues. And then part of the national plan is to have an integrated care record nationally.
Well, wouldn't it be appropriate at this stage, now that we're trying to have one major children's hospital for the entire country, and I know it will be dealing with ordinary issues in relation to children as well from the Greater Dublin area, but wouldn't this be the appropriate time as well to make sure that the entire system is digitised for children for all of the country at this stage? And I mean, like, what I don't want to have is a situation where all the Dublin hospitals are working together, and because it'll then be into one hospital, but Cork or Galway or Limerick won't be able to get the same access, and I'm just concerned that that will be left behind.
Yeah, and I think that's all part of the national plan to digitise the healthcare system within the HSE, to have a connected system. We obviously have a timeline issue with the new children's hospital, so we have got to progress our digital journey to get ready for that. But we are working very closely with our colleagues in the office of the Chief of the Information Office in the HSE around ensuring that we are aligned on the national plan, because we are cognizant, but that is a larger plan that is bigger than us, but we are definitely working very closely with them to deliver on that.
But have the HSE outlined to yourselves about the paediatric units around the country as regards how to coordinate this in together?
That's one of the assessments that's actually been undertaking at the moment around the implementation of the electronic healthcare record, is how would these work and how can systems talk to each other, particularly sending information to ensure that the clinicians, quite rightly in Cork, can have access to, and access to the data that they see of their child when it's up in Dublin. That's all been identified as one of the outcomes that's required of digitising the health system.
And the final thing in relation to computerisation is then the feedback to the general practitioners.
Yeah.
How is that being brought into the system then? Are we working with the general practitioners to make sure that they can get the relevant information as well?
No, thank you. You actually remind me, because central referrals is the other project I was trying to remember that we're trying to standardise within Children's Health Ireland. So yes, that actually would be with electronic transfer of referrals and then a notification back to the GPs of where their referral is in the system. So we're moving more to digital transfer of data and information back to the GPs.
Okay, but will that be all in place by the time the hospital opens in 4 years' time?
Oh yes, we're moving on that project. We've actually started that central referral. So with the implementation of the patient administration system, we have set up a central referrals office for general paediatrics. So we are kicking it off to whereby the referrals come in digitally, and we look to whichever of the general paediatricians has the shortest waiting list to get the children onto not just any particular doctor, but looking and managing it as a team of doctors and nurses, because of the nurse specialists, to try and deal with making it more efficient, and then electronically communicating that back to the GPs.
Okay. Could I just ask one final question? That's about the recruitment of specialists in relation to paediatric care. I mean, you're now competing on the world market, and I'm sure there are a lot of people that you would love to recruit but have decided not to move back. What is the big challenge that you're getting from people who are saying, sorry, look, I'd love to come back, but these are the reasons why I don't want to come back? I mean, is there any one specific area? Because now, obviously, developing a new children's hospital must be very attractive for someone who is just qualifying as a consultant, because there's going to be a huge range of new facilities available, state-of-the-art. It's obviously very attractive, but there's obviously some people still setting out the reasons why they want it. Because I've just looked at, say, childcare now in Canada, where it appears that they are finding it quite attractive to work in Canada or in Australia. And I'm just wondering, what is being said back to you in relation to that issue?
I would concur. We are in a global market, and particularly with some of the specialties in paediatrics. So, and they're multifactorial, and I don't think there's any one of them that is the magic silver bullet to this. But it would be worth saying. So we have identified that. We are looking at plans for key worker accommodation housing, because I think in Dublin we have a challenge around some of our key workers getting affordable housing within the Dublin area, and that's one of the things we've identified with the Dublin City Council to try and work and ensure that we have planning policies and options whereby we can look for key worker accommodation, so that and we're very keen to have a sustainable approach to our hospital, with people being able to walk and cycle to work and not having to drive miles actually to get to work. So that's one of our key objectives, and we're looking and have approached Dublin City Council about how actually we could progress with that. Other factor I would say is we have huge talented people that have left our system and wanted to come back, and that definitely, while it's great for people to go away, we do need to attract them back in, and coming back into something that's new and different and doing things differently is an attraction to the staff. They definitely want to be part of making a better difference, and not coming back to something that's the same. So we do need to progress with the transitioning of our clinical services to contemporary ways of working, and digitising our system is one of the ways of doing that. These people work in digital systems internationally, and hence can get and have great ideas. Pay parity is an issue for us, and restoration of pay parity is one of the factors that has actually been identified, and so that is an element that I think would help with some of the challenges. And then, as with everything else, people want to be part of something that's making a better difference to children's lives. So this project within the hospitals, the staff are very excited. see the staff that go out to Connolly, and they are, because of what they've come from a physical environment, and the way that they are seeing that they are leading and doing things differently is a huge motivational factor. And yet sometimes it is hard to keep that motivation when all they see in public in the media is my colleagues on the right getting focus around the costs. And the costs are, we're not trivialising them by any means, but we have a huge opportunity to really attract and retain some very, very highly talented, world-class people that actually are willing and want to return. But I do think the multifactorial issues around, some of the pay issues, but more important, coming back to a system that's just going to make a difference is what people want to be part of, and dealing with some of the pay parity restoration issues. I think all of those collective and housing are some of the factors that we're taking into account. And new roles and new different roles. Actually, people are interested in new roles and different roles.
Do you think the media? Sorry, do you think the media have negativised this project too much?
No, I think the staff would. We've actually assessed the staff, and they have been worried about the project. They've been worried it won't go ahead. They have given so much into designing this. They have set their dreams on moving into this. They have set they have real ambitions to actually deliver something that's better. So they're delighted it's proceeding, and are very happy to see. We do a drone footage that we send around every month to see the process, and I have to say the motivation and the sheer enthusiasm of the staff that are developing the new services is palpable, and they're coming up with ideas, and it's challenging. I mean, this is not all easy to do. Commissioning new services is a challenge and difficult, and we have some challenges there, but the staff are coming to it with solutions on how to address this. So I'm confident that with that engagement and contribution and motivation with our staff, and with further investment, we actually will be able to deliver this.
Thank you.
Thank you.
Ms. Hardiman.
Thank you, Chair.
Could I, before I bring in Deputy O'Reilly and Deputy Murphy, could I ask you, Mr. Barry, in relation to the PwC report, in the preamble to the recommendations of that report, the guaranteed maximum price established through the two-stage tender process does not provide a contractual ceiling on costs, and significant residual risks remain to further cost escalation. And then it goes on to provide its recommendations. And the PwC report was tasked with looking at the cost escalation, the reasons for it, and also to identify solutions to that cost escalation. So could you take us through your view of the PwC report in relation to increased governance of the project through the National Paediatric Hospital Development Board, and what measures you have taken to control cost escalation in relation to design and to the quantity surveyor costs relating to the project, because there does seem to be increased risk of cost escalation above the guaranteed maximum price.
Certainly. The PwC report certainly brought together, and it's in Chapter 6 of the report, that there are significant residual risks, as they refer to them, that are not included for within the GMP that's there at the moment. Those risks are there, and it is very likely that some of them will materialise. Most of those risks, not most, but certainly perhaps the most significant amongst those risks, is quite outside our control, and that relates to general construction industry inflation, which at the moment is running at higher levels than are included for within the contract. That the additional amount to be paid there, if there is an additional amount, is to be determined by formula based on various construction cost indices as they emerge over the next few years. So that is one area where there is a very, very real risk that additional monies will have to be paid. As I say, it's outside of our control. It's really outside the control of any individual. It's whatever happens in construction and the economy over the next few years. Other areas are more within our collective control, I suppose, and those would relate to, say, design changes being introduced. Now, the hospital, of course, was designed a lot of the design was done going for planning approval a couple of years ago, and the design developed since, but it's going to be another 4 years or so before the hospital opens, And it may well be that there are some changes in medical practice or in technology where it's thought on balance that it is best to introduce them into the project at this stage. They may lead to increased costs, or the view may be taken as we examine each of these one by one as they come up, that it's better to defer the change until after the hospital is completed. But those will be matters of judgment as we go forward, and of course CHI and ourselves will be working sort of hand in glove on those decisions and how to manage them.
Yeah, I think
From the governance point of view, we are at the development board level, we are restructuring our board committees to focus very much on our challenges for the next few years. The board committees have heretofore, as they should have been, focused on areas such as the planning and design. Now our primary focus is around dispute resolution on the construction and the whole commissioning and integration and IT and all of these things, where we need to work very closely with Children's Hospital in transitioning from a pure construction job to an operating facility.
Yeah, when the National Paediatric Hospital Development Board was here in, I think, the end of January, they identified a number of risks to the maximum price, the maximum guaranteed price.
Yes.
One was construction inflation, and it was pitched at 4%. Now, if construction inflation was to move to 7%, it would add 47 million. If it was to move to 10%, it would add 96 million. And if it was to move to 14%, it would add 166 million to the cost of the project. They also identified, as you've said,
yes,
there are new design elements which haven't been incorporated so far, because there was a rolling design in relation to
yes,
the two-stage process. And the PwC report identifies that rolling design as having increased risks to the costs going forward. Also, as you say, there are factors outside your control, such as changes in VAT and
VAT are statutory changes,
regulatory changes.
Regulatory changes, yes.
Also, the National Paediatric Hospital Development Board, at the end of January, had another risk, which was a scenario analysis, or they were going to conduct a scenario analysis to identify as yet unidentifiable costs. And I wonder, has that scenario analysis been completed, and have you identified other unidentified costs at the time which have been identified now? And finally, I think if the project was not to be completed in 2022 as planned, each month of that extension of completion would add a considerable cost to
yes,
the project, a number of millions per month.
Indeed,
most likely. So in relation to the maximum guaranteed price, then there are at least 5 factors which could lead to an escalation of a significant escalation of costs.
They could. That guaranteed max is a guaranteed max for what is encapsulated within the contract with BAM and their various subcontractors. And as you have articulated, and as PwC brought out, and as I'm sure the board advised the government and so on at the time, there are a lot of factors not included in there.
So the cost of 1.433 billion is most likely to be exceeded.
Well, my crystal ball and yours are no different, as to what will happen in relation to particularly construction inflation, I suppose. Of all the areas that are there, the construction inflation is the one that has such significant potential costs against it.
And have you introduced into the process a recommendation of the PricewaterhouseCoopers report, which said that there should be an independent body sitting between the National Paediatric Hospital Development Board and the design team and the quantity surveyor companies to check and to oversee what they are billing the project is absolutely correct?
I think the recommendation around an independent check was to do with the tender documentation when the project was being tendered. But I will say that we have strengthened our own team with regards to cost management and those areas to be able to better supervise what is being done by the design team and the quantity surveyors on the job.
And finally then, before I move to Deputy O'Reilly, have there been additional bills submitted from the design team over and above what was expected or what was within the maximum price?
Not from the design team. There have been a considerable number of claims submitted by the main contractor, BAM, who has claimed for additional monies, has claimed for extensions of time, has even claimed that the instruction that he's operating under is invalid, and so on. And we anticipate that we'll be receiving claims of this sort pretty well continuously from now to the end of the project.
And is that acceptable?
Well, it can't be stopped in that the contractor is entitled to submit claims on anything he thinks appropriate. Now, there's a process under the contract for dealing with these, and the claims through the process are finally determined by the employer's representative, who has to determine in a binding manner whether or not the claims have any validity, and if they do, to what extent and what the implications are. There's only been one of these claims so far has gone through that process, and the determination on that one was that the claim was unfounded and that there is no additional monies due. But this is the first of what will be a long sequence of such claims from now until the end of the project.
And is that the norm in projects like this, or has the two-stage procurement process led to this capacity to continually submit additional claims?
No, it is. In fact, the two-stage process would normally have led to a diminution in the number of claims being received at this stage. With the two-stage process, normally, when you complete the second stage, a lot of the issues that might normally give rise to claims and contention on the projects have been worked out and are captured within the guaranteed max price. However, there will still always be arguments in RAS on construction over costs and time. It's in the nature of the industry, and certainly I would say that the main contractor on the job, BAM, is probably a little more active in this regard than many other contractors are.
Thank you. Now we'll move to Deputy Louise O'Reilly.
Thanks, Chair. Good morning to everyone, and I apologise for having to step out. It was unavoidable. So my first questions relate to the structure, and just to media reports in the first instance that there would be a separate entrance for the private section of the hospital. And I'm wondering if you can just confirm. I'm actually interested to know where that came from, because clearly it came from someone looking at the plans. And then secondly, and in the same vein, as soon as this was spoken about, then there was a raft of people rushing in to explain that the money for any private medicine would be recouped. Now I've asked the Minister, and I'm asking yourselves today, is that in any structured way? This is what the private facility is going to cost? Because, see, if you don't know how much it's going to cost, then you don't know how much you're going to recoup. So you couldn't say with any confidence that you're going to recoup the money that will be spent on any private section in the hospital. Because if you don't know how much it's going to cost, well, then you don't know how much, and if you do know how much it's going to cost, well, then I'm interested to know that, and also the structured arrangements that will be put in place to ensure that that money is returned back to the Exchequer, because clearly, notwithstanding the attempts by some on the committee to reframe this as something other than a massive overspend or underestimation, whatever way you want to put it, at the end of the day it's costing significantly more. And the idea that, contrary to the spirit and indeed the letter of Sláinte Care, we're now going to be stacking in private care into a public hospital, I think is very disturbing for a lot of people. But perhaps you might just outline for us how that's going to work. Thanks.
And thank you, Deputy O'Reilly, and I'm glad to clarify that, because I do think there's been some misinterpretation maybe of information that actually has been shared in relation to the private clinics. So there is, when we say that there is an entrance, there's an entrance to all of the outpatient clinics that is an entrance off the concourse. That is what it is. It's not an external entrance or anything to the private clinic. So the way the hospital has been designed from an outpatient's perspective, as you can appreciate, that's a high footfall, and So we have a large concourse area, and each of the outpatients areas has an entrance off that concourse, and that was just written into the brief of how you get into the concourse. I think it might have been misinterpreted as if it was a special entrance outside, so it is no different. And the facilities there are no different to what in the public facilities are for the outpatient clinics in the area. There's 119 rooms in the outpatients, and then nine are a suite of 9 for private clinics. CHI, it's the policy position to have that there is clinics actually in public hospitals and private health medicine in public hospitals, and we know there is the report that has been undone, the Butler report, isn't it, from the Sláinte Care, and if there is a change in the policy position, like CHI will actually implement any changes in policy position and are willing to do that. But currently, at the moment, contractually, our clinicians actually, we have, as an employer, have an obligation legally to actually, they're entitled to see patients privately on our site. We have 3 private clinics in the existing hospital, so it is about following through on that.
Sorry, just on that, Eilish, would that be an increase in capacity?
It's probably
so the three clinics that exist
less,
at the minute,
I would say.
They will presumably. Will there be private facilities within the urgent care centres as well? Okay, so this is just for the main hospital.
Correct. And
it will be okay. So then, just a question on price.
Then is thank you. And I'd say if there's a policy change, we're willing to implement it. Because we can use that for public patients. So we actually have, and how we operate this is that clinicians who want to avail of it actually provide a fee. It's an operational fee that covers the running costs and the fees, and we haven't worked out those yet. But that's how the model is that we're actually proposing. So as part of our merger and integration, we're actually looking at the 3 clinics and the models at the moment, and how do we move forward to a model whereby if clinicians want to actually avail of these facilities and do that they will actually pay a fee for services and a simple operational method of actually doing it. So that's our plan to implement that.
Okay, but you haven't quantified the cost from
No, we're doing that as a
so that will be and will that will be public?
Yeah, we'll be willing to share that. That'll be,
no, I think that would be important.
Yeah.
The one of the main criticisms and something which we really struggled at this committee with was the extent to which the structure of various committees and who reported to who and who was on every committee, the structure was, and I put this kindly, very convoluted. Have attempts been made to streamline the structure? Because it was very frustrating for us as committee members trying to get information, but we never seemed to be talking to the people who were on the right committee or in the right room. And it did seem, and I think this is something which the PwC report referred to as well, have the structures been flattened out or streamlined in any way, shape or form?
Well, speaking first for the Development Board, the structures are quite complicated, I agree completely. At this stage,
well, convoluted is that's what I said, not complicated. It's convoluted, I think, is a slightly different meaning, but it was very difficult to penetrate. Put it to you that way.
Okay, for us at the moment, whilst the structures above us, so far as I know, haven't changed, although there may be change planned there, I don't know. Structures above us aren't really getting in the way of us doing what we have to do on the construction side. There were some key decisions that we needed, such as how the equipment was going to be procured, and we've been given those decisions. So really, from the perspective of the Development Board, we've got a clear road ahead of us, and if changes are made to the oversight, then of course we'll be working with the changed arrangements, but there isn't anything in there that's, as I say, getting in the way of us doing our job at the moment.
Okay.
If I may add that, I think for us it's gone a little bit simpler. We were dealing with 3 boards and our administrative board, so we, with the formation of the new board, I think, Chairman, you would say that it's just getting a little bit cleaner and simpler around decision making, which is helpful, and we would acknowledge that the project is now moving very much into commissioning and handover and all of those elements. So we are looking at how do we move to work with the Development Board on the decision making to make it fast. So I would like to feel assured the committee that between the Children's Health Ireland and the National Paediatric Development Board at executive level, we have very clear, robust ways of actually working and work very closely together. And I think the boards also have would work that. Yeah. I think anything above us is we would.
Yeah, I would agree. I think that the legislation has provided for very great clarity around the existing hospitals, and I think the achievement of bringing together the existing hospitals is a major achievement. The fact that Crumlin and Temple Street essentially shut down their governing authorities and passed authority to us, I think is a huge step forward, without any baggage in terms of any ethical issues or whatever. I think that was something that was done very well. I think great credit is due to the people involved, to the boards of those hospitals, and indeed to the religious orders and the Archbishop of Dublin, who I think did a fabulous job in terms of, if you like, seeing that transformation take place in a very, I would say, under the radar, but very quiet, but very, very efficient way. I'd say there is necessary complexity in a project like this, because I think we have a role as a board in terms of managing existing facilities, which we now have control of, acting as client for the new hospital, and also preparing for a new facility and preparing our services. That provides tremendous challenges, and that's obviously complex, but I think our board is up for that. I would say in terms of the other complexity, it arises from the fact that the funding of the hospital is public funding, and therefore the control of the budget is not under control of my board, or indeed the Paediatric Development Board. That's unusual, but that's necessary in the context of public investment, so we recognise that. There's also necessary complexity associated with standardisation. We all agree there has to be a national electronic health record. That has to be across the service. We have to, on the other hand, we have got to progress a digital hospital. We have to do that in the context of a national standard.
That's why it would be very difficult to progress a digital hospital in the context of a non-digitised health service.
I agree, but we are the sharp end of the wedge in terms of getting that project started. But on the other hand, we can't simply go off on our own and create our own record. We have to have cognizance of the national picture. So that creates complexity. Yeah. But that's
I wouldn't wait for the rest of the HSE to catch up. I would probably be more inclined to forge ahead with it. Yeah. No, I take those points.
But I think the system is working well. I suppose that's what I'm coming down to in the end. I think there has been there's much better clarity than there was now.
Yeah, I suspect your predecessors thought their system was working well also, and unfortunately it wasn't in all cases. But look, the hope is that the hospital will be built and get additional capacity put in. Can I just ask with regard to the urgent care centre in Connolly, and apologies if this question was asked already, but I have asked the Minister this and he wasn't able to give me an answer. Will it open from 8 a.m. to midnight 7 days a week? Yeah.
No,
from the 31st.
Earlier.
That was answered. Okay, yeah. Okay, that's fair. Now I can look back over the records.
Thank you.
With regard to the provision of staffing services for the urgent care centres. Okay, so the fear would be that the staff would be taken from the existing hospitals. So if you take radiology as an example, we're already 40% short paediatric radiologists. In order to be able, we have to add that 40% in to maintain the basic standard, and then obviously for any additional services. I'm just wondering, in terms of it's not so much a plan, because at this stage the planning obviously is done. It's in terms of personnel. Are they ready to go? Because obviously at this stage they'll have given notice from wherever they are. They'll be on their way.
Yeah, and I think, and you're touching on what is a challenge, and we've recognised that. So we started way back last year actually trying to implement and plan this. So we have particularly around, which what we don't want to do is, take out very experienced personnel from one area, and as a result then causing, a vacancy rate or concern risk. So we have worked very closely with the management in the children's hospitals with their direction to risk assess the staged approach of actually opening. So we've identified where are the staff who actually have gone for, and well done, have got promotional posts, and if they've come from one particular area, we've looked at a staged and release for them with their agreement, and we have managed to go and at the same time do
I don't understand what
so
that
if
means.
there's 3 nurses from one ward want to go out and move out, 3 nurses going from one ward altogether is too much to actually happen. It will cause a concern around maintaining services in a ward, let's say in Temple Street or Crumlin. So what we have have worked with staff is that people are going out, 1 month or 6 weeks apart, and we've actually identified backfills that have come in and have started very, very quickly, so that there isn't a drop in the numbers in the ward. So we've worked very closely with nursing to identify where are the areas they're coming from, is there a risk concerned with them moving, and have we got a backfill very quickly identified.
Well, I think the wider problem is one of understaffing right across the hospital.
I'll come to that. I was just on about, because the biggest numbers are nurses, so that was one of our biggest challenges. And you are right then. So, for example, in imaging, in radiology, we've gone out for 5.65 posts, in new posts in imaging, and of that, 2.65 of them have actually have been accepted, or 3.65. So we ended up with 2 vacancies at the moment that we haven't been able to fill. But what we have been able to do is work, and we are working with the imaging staff around how can we actually address this, because we have a challenge in imaging full stop, as you have identified, around the demands for the services far outstrip the capacity that we have. So we're taking this in the round of what it is. So it's not just about Connolly, because it has moderate requirements for imaging, and it's plain film imaging. So we're looking at all of our imaging, working with our radiology consultants, and working with the HSE through NTPF and other ways of insourcing and looking at the other elements in the public system to actually address a capacity challenge that we actually have at the moment. We have identified then proleptic appointments and putting in some more a pipeline of staff. So we've increased our specialist registrars in imaging, so that we have future pipeline of clinicians coming out in this area, which is it's a national and international challenge. So we're working with very much with the areas, and so we have identified better ways of actually using our existing resources to try and put in capacity plans, very much with and in conjunction with the staff involved.
But if you have better ways of working within existing resources, you have to acknowledge that the existing resources are not sufficient.
We do.
It's only very recently that the INMO have started to count trolley waiters for children's hospitals. Yeah. I mean, that was a new departure, and an area they never went into previously. That's right. Primarily because it wasn't much of a feature. It was becoming more and more of a feature, but they count it now. So that's obviously a very clear indicator that there are issues with regarding staff. And so, I mean, you're talking about backfilling as staff progressively move out. But if you're only backfilling to the current level, you're still going to be understaffed in the original hospitals, if you will, before people start to move. And there is a genuine concern among staff that the push is going to be on to open the urgent care facility to the extent that it is going to leave already hard-pressed staff back in the main hospitals more understaffed as personnel move out. And I know that you're saying that the plan is that you'll backfill very rapidly, but if the staff were there to backfill, why are they not there to fill the roster to ensure that the staffing levels are maintained at what they should be? Because I don't think there's a grade group or category of worker in the hospital, outside possibly of administration, where they are operating on a full staff complement.
No, I totally concur. We actually have a staffing plan that's identified increased staffing, which does need to be funded every year through the estimates process as an investment in paediatrics. And we have evidence-based that with comparable international services, and there's nobody disagreeing with us that we actually have identified deficits. And we within Children's Health Ireland have identified where is our priority areas for investment. We know we can't do it all in 1 year, and we very clearly have worked across the 3 hospitals. That's the clinical directors, the nurses, managers, and the head of the health and social care professionals. And we have identified and prioritised our areas for investment. Now, I am happy to say we've had the largest investment in paediatrics that has happened in 2018, with an additional 173 posts coming in to Children's Health Ireland. Vast majority of them are clinical, and we are working hard to actually see that. But we do need we are confident that we need further investment, and we will be identifying that as part of that annual investment process, and all of that has been identified in our future workforce plans. And we have a challenge whereby there's only so much capacity within the existing hospital, so it's a real challenging area that we're in at the moment, because if you walk around Temple Street you can't squeeze anything anymore in there. So what we are trying to do is, which is very welcome, and that's why people welcome the new investment of the new facilities. So it's not seen as in competition with each other, because we're seen as taking some of the pressure out of Temple Street in particular, so that we can actually concentrate the kind of tertiary high-end services within the hospitals and get paediatrics and general paediatrics and them actually, and orthopaedics and others out into Connolly, which will gratefully help. So we are looking at strategic alliances, through the NTPF and others over the next few years, because we are going to have to increase our workforce, because we can't leave it all to 2023 to do a sudden leap. And we do have a kind of evidence base with our waiting list that we do actually have a requirement for further investment. So with the HSE and the commissioning team for around children's health, we have mapped out what we think this do, identifying as well the pipeline. Can we realistically fill these posts? And some of that means that we've actually set up a whole workforce planning group with the HSE. We have got subcommittees of it specifically relating to nursing, because of the quantum of the numbers actually involved, and have identified a very clear action plan for the supply and demand in nursing. We have worked up as well with our colleagues in the doctors training unit about the future, particularly SBRs and pipeline for that, and identifying colleagues that have gone internationally that would like to actually return, and when they see the investment and happening, and we are making some progress with that. That's slow and it does take time, and there are niche areas that are particularly challenging to fill. And then the last one we want to work with the health and social care professionals. While they're at the highest numbers, but there's a lot of them, so there is a need to actually ensure that we have both a pipeline, and when they come into us they can actually have somewhere to work. So it's quite complex, but we're feeling that staffing, I would say, Chairman, from the board's perspective, when we look at the project, while we engage with our colleagues in the build, we really have moved off the building to very much about staffing and ICT. There are big areas of focus to try and deliver a good service when we get the building.
One last question, very briefly. And I appreciate that this was covered while I was out, but just, have you enough paediatric emergency consultants to open from 8 a.m. to midnight 7 days a week in
Not
Connolly?
at the moment, and that's why I was saying we actually have a stage approach, and we're working with the paediatric.
So just with what does the staged approach mean? Does it mean
means
9 to 5?
Less hours, yeah. And we haven't concluded those yet, because we're still working with them, and we have some of our clinicians are on maternity leave and returning, so we have to build all that.
When are they returning?
They
would be easily identified. No, I completely withdraw that.
But
No.
we have a plan.
So so it's not going to. It's definitely not going to be.
We're saying on a
8
phased
to midnight.
approach, and I think that's sensible in a new facility and getting into it. And also, it's our.
I don't necessarily think it is sensible. I think what we were promised, and bearing in mind that the kids in my own constituency will be some of the main users of this facility, and what we were promised was 8 a.m. to midnight starting on the 31st of July. So that's not going to be the case, and it is, you're saying, most likely 9 to 5, or you're still working on that?
We're still working on that, and we will be communicating that, but I mean, it's done in a way that's safe and progressive, and we can see how we can actually up that. And we've talked to our colleagues internationally, have done this. They haven't gone big bang first day. They've actually built it up over a period of time, and that's our intention to do that. And we have got some resources coming back that actually would help us do that. And happy to communicate that plan, Chairman, when we have it actually concluded. Thank you.
Thank you.
And just in relation to that then, eventually, when the whole project is complete, the satellite centres in Connolly and Tala will be ambulatory centres. There will be no overnight beds. If you need admission, you'll be transferred to
the Children's Hospital.
To St James's.
Yes.
And the opening hours eventually will be 8 to midnight?
12, yes. Okay. Last patient in at 10. And again, just to be clear, the reason we've done an awful lot of healthcare planning at the attendances to our existing hospitals. When do the children come? How long do they stay? What it is. So this is very much based on an evidence base, and it's very much based with the clinicians actually working on planning that. Yeah. Thank you, Chair.
Thank you very much. Now we're going to move to Deputy Murphy.
Thank you, Chair. I suppose, first of all, I'd like to welcome you all here this morning and thank you for giving up your time and for the information so far. A lot of what I had planned to ask has been asked already. I suppose that's the disadvantage of going last. Just maybe to clarify a few things, please, Ms. Hardiman, the staged opening, is that time only, so not service?
Yes.
Okay. So time only, okay. And with regard to the 31st of July, are you as positive as you can be, obviously, that is the day?
That's the date we're in. Yes.
Okay, okay. Again, I suppose I would have thought that an opening day would be fully, that the plans that we had heard would be happening there would be happening from the 31st of July. So that is a bit disappointing. That and I presume must be hard enough to manage as well a staged phase like that. You know, would you not? I just find it hard to understand that it can't be just open on the 31st of July as planned.
Yeah, and I think we've been very fortunate, as in we've managed to attract, 7 new emergency medicine consultants back to our services. I mean, that is, quite, a good achievement. But we have some people who have taken leave, or maternity leave, which just happens in the system. So, and we have paediatric emergency department consultants who are very committed to this project. But some people, we have some locums that are harder to fill than permanent posts. So we feel we can fill permanent posts, because people will return for permanent posts, but locums is where we actually have a challenge. And we had some people doing locums who now got the permanent posts, which is good, to see progressive. So we want to be doing this in a way that's safe for the existing hospitals and safe for the new facility. August is one of the quietest months for us, so lots of people have been away and everything else like that. So it is going to give us a time, and we have opened up facilities before on a staged basis. Okay. While we do all the pre-testing and everything else like that, we want to do this and we want this to be a success. And while yes, it would be preference if we had every single post filled, but the reality is, staffing is a challenge in the health service, and we're no different to anybody else. I think we've made great inroads, and with the continuous working with the staff, they will come up with a process and a staged approach, because everybody wants to make this work for the children.
Okay, and I remember reading there a while back that he filled 10 out of 13 consultant positions. Is that still the case?
Correct.
Okay.
Well, actually, one of them now, we have a recruitment campaign that has been advanced, and we have candidates in that are being shortlisted. Yeah.
Okay. So again, just a matter of time.
Yes. Yeah, we do. We think hopefully there will be appointments out of that one. Yes. Yeah.
Okay. And I'm glad that the issue about the private paediatric practice has been clarified, and I very much welcome that. Just with regard to the Children's Hospital and the physical access to it, as was. When there was talks about the positioning of the hospital here, the road and the infrastructure came up an awful lot, particularly to ourselves. And I know it's probably outside your brief a bit, that side of it, but are there any plans just to make things a bit easier for people to get to the hospital? As in physically, infrastructurally?
Well, as you say, the physical infrastructure outside of the hospital is, of course, outside the brief of the Development Board.
Yes.
Elsewhere, the National Transport Authority is working on things like bus connects and other programmes to try and improve transport around the city. And the Development Board and the NTA will be working quite closely, I can assure you, about
and
the plans.
Do they keep posted, after they meet and all that, or are you just separate?
Sorry, Deputy, you may not be aware of this. I have an involvement with the National Transport Authority as well, so yes. I can assure everybody that there will be close coordination between the Development Board and the NTA. There already is.
Good.
There already is.
I think it's important that will be sorted.
Debbie, I might be able to add to that just for me. We have a sustainability and mobility manager appointed at the campus at St James's, between Children's Health Ireland and St James's, and he is very much leading on a sustainable future and implementing and working and making sure that any of the policy issues that have been implemented, that the campus is taken into account. We also are working at, again, using digital and our phones, and actually when a facility whereby if appointment is made, that you'll be able to get Google to where that exact appointment is to actually guide and help parents and families, so they're not stressing about how's the quickest, fastest way of actually getting to it, and including, you know, as I was saying, the 675 car parking spaces, which is 3 times more than what we have in the existing children's hospitals. So just to re-emphasise, we have taken access, and particularly parking, because when we talk to parents, they get to the hospitals. I mean, Temple Street Children's Hospital has to be the most inner city hospital we have, maybe with the matter, and they actually can get there. It's just when they get there, they can't get parking. So we really did put an emphasis on projecting the parking requirements, while at the same time, you know, the campus has some of the best public transports for those that don't need to get in car, and we know that that's not the children and families, but some of our staff and visitors and our students in particular.
That's good to hear. And sorry.
Thing on that, sorry. Just the other thing I think, which is, because this is a new build, obviously it meets all of the, you know, the wider understanding of access. It meets the wider accessibility requirements. A lot of our children would have disability and might have assisted ambulation and that. And so with the design of the hospital, the first floor of the car park feeds directly into the outpatient department. So it's a level walk-in.
Oh, good.
Underground, so dry, secure, with adequate width for children getting out into buggies or wheelchairs, and then direct ambulatory access from that car park into the outpatient department.
Yeah, I very much welcome that now.
Yeah,
that's good. And just one last question. Do you plan in developing a charter for the new hospital?
There is a patient charter that we abide to. We actually have already developed our values, vision and mission for the Children's Health Ireland. We did it based on all the good work that the 3 children's hospitals, other many histories, have actually been doing. So, and we ascribed to the UN Convention on the Rights of the Child, and we also have the European Charter for Children's Hospitals. So all of those are very clearly driving the values and vision and mission of our entity. Yeah.
Okay. Thank you very much. Thank you, Chair.
Thank you very much, Deputy Murphy. Deputy O'Connell, do you want to settle? Yeah, okay, thank you. So we're now going to return to our second round of speakers, and Deputy Donnelly. Thank you.
Thank you, Chair. Thank you all for your ongoing energies. It can be grueling. I imagine it's a lot harder over there than it is over here. Chair, before we come to our guests, I really just want to thank Deputy Durkan in his absence. He made some quite extraordinary statements earlier on, which fit neatly into Orwellian doublespeak. From what I can see, he seems to have recast a €650 million budget going to €1.7 billion as not an overspend. There was no overspend, there was no overrun, it was simply an underestimation, which is extraordinary. It's a bit like, you know, agreeing a price for your house with a builder who says, look, it's going to be €200,000, and the builder comes back 18 months later and says, well, actually, we need more pipes and wiring than we thought. It's not 200, it's 600,000. But the good news is there's no overspend and there's no overrun. There's just an underestimation. I do think, on a serious point, though, the amount of taxpayers' money, public money that is being used, I think is recategorisation. I think it is an insult. I think it's an insult to everyone who uses the healthcare system. I think it's an insult to everyone who pays taxes. The idea that we would dismiss an overrun from 650 million to 1.7 billion euro and counting, sounds like it's going to go a lot higher, as not an overspend, as not an overrun. I do think it's I do think it was an insulting. It's an insulting re-spinning of what we all know has actually happened. Ms. Hardiman, on private practice, I'd like to just go into this with you a bit, if I could. There was a public report that there would be a private entrance as part of the hospital. Now, I asked the Minister, and he came back to me in writing, I think just yesterday, and said...
We actually dealt with that.
No, I was here. I'm continuing further into it, Chair, thanks. And he said that there wasn't going to be a private entrance, but what you confirmed to Deputy O'Reilly was that within the concourse, there will in fact be a private entrance, if I understand it. There will be a segregated entrance that will lead to dedicated consulting rooms for private patients. Is that correct?
So just to be clear, all of our outpatients are off the concourse, and each of them have an entrance. We just have, that's how the suites are done, the outpatient suites. And one of them is, is 9 rooms, that is the private clinic.
Yeah.
So there is an entrance into it. It's the same for all of the rest of them. They're designed actually very much like modules so that we can have flexibility. So what we don't have is, for example, is in the middle of an outpatient's one room that's private. What we have is 9 rooms that are off the concourse.
So
like
it is so it's not the case that a consultant working in the hospital is doing their public practice. They can rent one of the public rooms and do private work there.
Correct.
There will in fact physically be a separate entrance to physically separated suites for private patients.
So maybe just saying that all of the...
Can I just get, that's just a yes or a no. Will there be a separate entrance to private suites?
My response, Deputy Donnelly, is that all of the outpatient suites have their own entrance. It's no different to the public ones that we have off the concourse. It's built the exact same way.
So to be clear, you're confirming there will be a separate entrance to private suites for private patients?
Correct.
Okay, thank you. Is it the case then, we're all aware, you're all aware, we're all aware in this country that there are huge waiting lists for children to get access to diagnostics, to get access to treatment, but not if you pay, not if your parents can afford the treatment. So are we potentially looking at a children's hospital where children with the same condition in need of seeing the same consultants, one child whose parents can't afford to pay might wait 2 years to see a consultant going through one door. It might take you 2 years to get to see the consultant through that door. But if your parents have the money and you have the same condition, you can see the consultant not in 2 years but in 2 days through the private door. Is that potentially what we're going to see?
Well, I think that's what the system, and that's what Slaughter Care has identified, and that's what the De Butler programme.
And we're physically building that into the new children's hospital.
Well, I think because we have a legal remit at the moment and a policy remit. But as I have reinstated, if the policy changes, this is no problem. We can actually implement the new policy. I would say though that in paediatrics, vast majority of our clinicians deal in the public system. It is a much smaller element of private care or private services in paediatrics than it is in the adult world.
Thank you. And I take your point. It is a policy.
It is less
decision.
less than 10% even of our facilities.
Can I ask, to the best of your knowledge, and maybe no decisions have been made on this, I want to ask the same question in terms of access to diagnostics. Right. So if you take Temple Street today, a child who needs an MRI in conjunction with a general anaesthetic, there is a 27-month waiting list over 2 years. It's the longest anywhere in the developed world. In the new hospital, assuming there are still these waiting lists, will it be possible for parents to pay to have quicker access to diagnostics, but obviously on the same machine as the children who are waiting over 2 years?
Well, my first reply to that is our intention is to have the waiting list issues addressed before we move into the children's hospitals, because we have identified that we don't want to design how it's going to operate based on...
I understand that, but let's assume there are waiting lists in the future.
No, but just to follow through, so that's our intention, is to actually deal with that, because you don't design a new hospital to function and operate on something that's maybe not functioning and not operating to the best of its ability at the moment. We also have identified that it is a priority to actually have our MRIs replaced. They are very old in our hospital systems, and in both Crumlin and Temple Street, and HSE are working with us and understand that, and that would actually help us. And we are looking with, again, putting in hours of working and how can we actually increase the throughput.
I understand the caveats, but it's a direct question, which is, will private patients have access to diagnostics through publicly purchased diagnostic machines like MRIs?
So as you would appreciate, you're right, the inequality in the system is access to the outpatients. Once you get then a referral to use a facility within the hospital, be it like day case, inpatient or access, that goes on to the list. It's prioritised according to clinical need. So access area that you're identifying, the inequality, is in the outpatient's opportunity to actually get to see a consultant earlier than you would in the public system. But once you get referred on, you go into then the list as everybody else does, based on clinical need.
Okay, I'm not sure that people who are watching will know what the answer to my question is based on what you said. I'm not saying you're trying to avoid it,
No, I'm not.
but could you give it, it's a simple question. You might give a very clear answer. The simple question I'm asking is, we have publicly purchased MRI machines. There's over a 2-year wait in a lot of cases for children to just get a scan. Will it be the case that parents will be able to pay so that their children are private patients, so that they can use those machines in a quicker time than if their parents weren't paying?
No, what we have is that they will pay to see outpatients earlier, and if they require the access to either anything else, machines, labs, inpatients, theatres, that goes on to an internal waiting list.
With no differentiation?
According to clinical need, and they still have to pay.
So if you have a patient coming in as a private patient, at the moment, due to the system, they will see the consultant a lot quicker.
Correct.
We know that. Now, a public patient and a private patient seeing clinicians on the same day, and they're both sent for MRI, and they have the same level of medical need. Is there any difference in the time of access between the private and the public patient?
No, and I think what we find is that they use other private MRI facilities to get those done.
They'll go outside the hospital and come back in again. Okay, but not the public machines?
Because we are just a huge waiting list.
But not the public machines?
No, or not faster than the public machines.
Okay, thank you. On recruitment, there's been a lot of talk about Connolly and the fact that the urgent care facility is going to be run for significantly less hours, it sounds like, than was wanted. Part of the reason for this, my understanding, is there needs to be 6 whole-time equivalent urgent care paediatric consultants, and between the jigs and the reels and the fact that we are dealing with the recruitment and retention crisis, it'll be sort of 1.5 to 2 at the moment. Can I ask, as someone who's involved in trying to hire a lot of doctors, and we know that they're like hen's teeth here and around the world, one of the big issues that's been identified is the new entrant pay disparity. In your experience now, going around trying to hire doctors, and we wish you the very best of luck and want to help with that, could you name 1 or 2 things, 1 or 2 changes that could be made, as well as getting rid of this new entrant pay disparity, that would help us retain the doctors we have, move from locums to permanent staff, who, you know, which is what you want for a sustainable model, and make it easier to attract home some of the paediatric consultants around the world who want to come back and work here?
Okay, I might have answered this a little bit earlier when you were out, but I have no problem actually repeating it. So yes, there's multiple factors that we think would actually help us in both recruiting and retaining our staff. Yes, pay parity is one issue, and restoration of pay parity would be one factor that would help. But I think what we're experiencing is helping our staff to actually get affordable accommodation in Dublin is one of the priority areas that we've identified, that we would like to work with Dublin City Council and others to ensure that we have affordable housing. We are actually working as well on policies around affordable housing to ensure that our staff can sustainably get to the hospital as opposed to driving many miles to get to the hospital. So that is another element we want to work with. We find the digitisation of the system would help, because people are coming from a system that's digitised, so they want to work in a way like that, and they're coming with lots of ideas on how to connect with their families and patients and their other clinicians, and so ways of trying to support that. And not all of that is new electronic healthcare records, you know, that's just looking at apps and other ways of actually doing it. But I think the most important thing that when staff come back and they're talking to us is about, they really want to make a difference. That's it. They're fundamentally here because they want to care for children and want to make a difference. And they want it, so the new buildings and the new ways of working actually attract them. They're up for the change. They're up to actually be rostered until 12 o'clock at night, because it makes services better for children. And for me, I think it's about ensuring that we support that as much as possible. And while we've 7 new ED consultants who have come to us, what we have is some of them are on maternity leave. That's just the reality of the challenges. There are temporary reasons to why we can't have everybody in the positions. And we have 2 people in promotional posts. So there are reasons whereby we seem to be able to fill the permanent posts, but it's the locums are where we actually have a challenge in filling them. So we do need to actually look at also addressing some of those challenges around accommodation, pay, and also I think ensuring that the team we're putting in is an interdisciplinary team. They want to work with new roles, new people, like, you know, the general paediatricians, for example, are getting, you know, clinical nurse specialists. They've never had clinical nurse specialists before, and it's making such a difference to how they deliver their services. So we need to look at that investment, just not being without doing the same old, as I keep saying, but using digitisation and using new roles that actually are delivering better value to the patients.
Thank you. I'd like to ask you about Holles Street, if I could.
Yes.
The one of the big sells of the Children's Hospital was trilocation, adult teaching, maternity. There has been no movement in Holles Street. The planning and development phase hasn't started, and we found out at committee recently enough that not only has it not started, but there isn't any money even budgeted to begin the work this year. Can I ask, do you have any insight into why something that was trumpeted as being a critical part of this healthcare campus for children, but also for mums in the maternity hospital, why nothing seems to have happened? Have you any insight as to why that's just been stuck?
Well, am I to divert to my...
Coombe rather than Holles Street.
Oh, beg your pardon, sorry, the Coombe.
Oh,
yeah.
good.
Yeah. Thank you, Chair.
Came as a surprise.
Yeah. Trilocation is still an objective, and the board have actually discussed this, and the board would, and we've actually discussed it with the master in the Coombe, and our medical boards and the Coombe have actually come together as well about how we actually implement this. And trilocation is key, so James's is important in this element, because when it comes to maternity services, it's not just the children, which are where we want to see the synergies, but also the mum with James's. So the 3 chairs are actually meeting to see how can they actually progress that from a board's perspective across the 2 chairs. We do believe that there is some planning elements of that could happen that are not resource intensive, but do require and need to be done from the clinical
I guess, sorry to cut across you, but I'm asking a different question. So the answer you're giving is the answer that we have been hearing every year for the last 5 years. The people are meeting and it's very important, and we really, you know, it's terribly important that it must happen, and everyone's talking to each other and required. We've been hearing that for years. My question is, have you insight into why pretty much nothing has happened over these years? We're in the middle of building the Children's Hospital, and there isn't even the budget allocated to begin the planning phase for the maternity hospital. Do you have any insight into why that has happened?
I'd have to defer to my colleagues in the HC department. Thank you.
Well, just to come in, I suppose, from a policy perspective, I mean, the decision to site the Children's Hospital on the James's campus and the subsequent decision around the co-location, you know, was made by government a number of years ago. Obviously, the maternity hospital is part of the strategic investment priority in the NDP, but, you know, the construction of the maternity hospital won't commence until the new Children's Hospital is completed. Like, that's just a reality. But the Minister has been very clear in terms of his commitment to the project in previous committee appearances and elsewhere, including in the Dáil. And that commitment is shared, as Eilish has said, by the CEO of James's Hospital and the Master of the Coombe. The site for the proposed maternity hospital is identified in the site master plan for the campus at St James's Hospital. It's a core element of the maternity strategy. Can't commence until the Children's Hospital is completed. And I suppose in maternity policy terms, the focus has been in relation to the NMH, and we've been in detailed discussions around that. And my colleague can talk about the monies that are available in the capital plan in relation to the NMH. So we're pursuing a policy of tri-location and relocation of the existing maternity hospitals, starting with the NMH and then moving on in terms of the Rotunda and the Coombe. So, I mean, I suppose, you know, that work will be ongoing over the next number of years, such that we'll be in a position to move as expeditiously as possible to commence the works once the Children's Hospital is completed.
But with respect to the last bit, self-evidently, that's not true, because were that true, the planning and development phase would have started. So you may be saying that for engineering reasons or capital reasons or whatever it is, we're not going to build the two hospitals at the same time. I have no technical view on that. But that's not where we're at. Where we're at is we're in the middle of building the Children's Hospital, and the basic preliminary design and planning work hasn't even started for the maternity hospital. So by definition, we're not moving as expeditiously as we could to be in a position to start building the maternity hospital as soon as it should. Like, by definition, that's not where we're at, which is why I'm asking the question. That's exactly what we should be doing, and we're not doing it. So my question is, why are we not doing it? Why have we not even started the planning and development phase, which can take years? I mean, God knows, Ms. Hardyman was involved in this Children's Hospital on 2 different sites over many, many years. That's all planning and development.
Deputy, it does relate to the priorities set out in the National Development Plan for a broad range of large projects, and the maternity hospitals. There are a number of projects identified in the development plan. So clearly it's a question of proceeding as the available capital programme allows on an annual basis and a multi-annual basis as to what we can actually achieve. The priority at the moment has been the preparatory work around the move of the maternity hospital out to the St Vincent site, and there is funding already in the capital plan for that preparatory work, and that pre-preparatory work is already underway in terms of preparation of the site. That is the work that's going on at the moment on proposals on the development of maternity services. The other projects, such as the COOM and others, are slightly further along, and there was a decision that it would be in conjunction with the development of the Children's Hospital, and the Children's Hospital would be completed first. So it's within that sort of timeframe we're working on the development of maternity services generally.
Okay, thank you. Could I just two final questions? I might pose them at the same time. Mr. Barry, one is I think a short one for you. Going on from the conversation you were having with Dr. Harty, you said that some of the additional overspends, or, you know, in Deputy Durkan's world, further underestimations, but further overspends, that it's highly likely that some of those risks are going to come to pass.
Yes.
Do you have a sense at this stage as to what level of cash we might be talking about? And I'll just ask my other question at the same time. Dr. Curtis, it's really just an open question to you, as you're the clinical director for the project. Is there anything else that we in the Oireachtas should be doing or could be doing to help you and to help the clinical teams get ready for this transition and to provide the best possible services in the short and the longer term? Thanks, Chair.
Thank you. Sure. Taking the first question in relation to how much are we likely to spend over and above the 1.43 billion, I don't really have a good sense of where that's going to land. We've years of construction to go, and in particular years of inflationary pressure, but all sorts of other pressures as well. And I would be almost misleading you if I were to offer figures against it.
Do you have a sense for the is it in the tens of millions or hundreds of millions?
Well, certainly tens. The biggest figures, of course, in any speculation around this that I've seen have been the calculation which is included in the PwC report on inflation. And if inflation is high enough, then it will be, excuse me, it'll be at that sort of level.
In the tens of millions?
It'll be more than, well,
in the
high enough inflation. There's a table in the PwC report, and it sets out scenarios ranging from 44, I think it is, to about 140, 150 million in relation to inflation alone.
Okay.
And sorry, excuse me. Those are the biggest figures that I've seen around any of the risks.
Yeah. So, okay. So we could be in the hundreds of millions, but we don't know yet.
It's too soon to say.
Okay. Thank you.
I suppose it's like such a broad remit, but I think
I thought we'd finish on a nice question.
Absolutely.
What can we do to help?
This is such a huge and wonderful project, and yet it has felt really attritional and difficult and challenged, and that is entirely reasonable because of the difficulties the project has faced over the time. But I think one of the consequences of it has been that for the staff in the 3 children's hospitals, and I suppose paediatric services and children and families who will avail of it countrywide, that there has been doubt and confusion. Will it ever happen? It's a poison chalice, it's dogged. I think we have done really good work on planning and designing, and our aim and intention is to provide a facility that will really... We have great staff, like really good staff in paediatrics in Ireland. Almost all of them have trained outside the country. Where they haven't, they've been trained with the best people here. And it isn't obviously the building that makes for excellent care, but a building, poor circumstances can make excellent care more difficult to deliver, and good environment and resources can enhance your ability to deliver excellent care. So I think what I would like to see is that the perception of this as being something positive would emerge, because I don't think that's how people see it. And I know the design inside out. I work very closely with the CHI, so I know the work they're doing on integration. And I think it's going to be absolutely excellent. I think it's going to be a really good place for children who have illnesses and conditions and who need medical input, which is a shame, because ideally childhood would not be marred by those occurrences. But that, I think in some way, it's important that this is seen for what it is, which is a fantastic investment, long overdue, in the health and well-being of the children and young people of Ireland. And that obviously isn't only the responsibility of yourselves, but I think we're all part of ensuring that it's seen in that way rather than seen as something terribly negative, which is sometimes how it feels. And I suppose the second point would be, Eilish has talked about the difficulties in staffing and, the genuine challenges in merging 3 hospitals and doing all of this new thing together and commissioning 3 new buildings. I suppose any support and input and wisdom in terms of the Oireachtas supporting the department, which is a huge supporter of this project, the HSE, which is really integrally involved in it. I mean, we're not in this on our own. Like, everybody here is involved. And I suppose any support the Oireachtas can give in guiding and just supporting us in the job, the really challenging job we have to do, would be really welcome. Because it's, I think it will be fantastic. I think it will be an incredible benefit to children and young people in Ireland, and I think it has the potential to really, through its network and through its working with primary care and community, not just about the hospital, really enhancing the health and children, of future children and young people in Ireland for decades into the next century.
Let's hope
so. Thank you for that question.
No, not at all. Thank you. Thanks, Chair.
Thank you very much, and thank you very much, Dr. Curtis. Now, we'll move to Deputy Louise O'Reilly.
My questions again relate to staff, and so just arising out of the and if we could just maybe refrain from there's a global shortage. We do all actually know that, but specifically what we want to know is what is being done here. So with regard to nursing recruitment, at what advanced stage? Because presumably if there's going to be an expansion of service, then we're going to need more qualified nurses than we have at the minute. So given the likely timeline, those nurses are either doing their leave insert now or just finished it or just finished their first year in nursing. So in terms of how they're going to be phased in, could you give us an idea just in terms of the numbers? Have you sourced them? I mean, a recent survey from the INMO, and I met some of the student nurses myself, indicate that they have no intention of waiting here. They have every intention of emigrating. They have no intention of working within the health service, and like from my previous work, I would know that cohort of workers very well. Traditionally, they would go away for a year and come back. They're not coming back. So is there a specific plan in place? Is there any incentivisation? Is there anything being done with the universities, and have any of them given anything like a commitment that they are going to stay? Because without the staff, we just have a massively expensive building in which no services can be delivered, and it is the aspiration of the Oireachtas members to work with the people in this room, because we all want to see the hospital built, but it becomes increasingly more and more difficult to imagine that it's going to be staffed, given the absolute crisis in staffing that exists within the health service at the moment. Thank you, Chair.
No, and thank you. And again, to reiterate, I mean, the whole workforce and ICT are the two areas that we're really focusing on, on trying to ensure that we're able to leverage the investment that's been made in this capital investment. I suppose it is of assurance to us that we have an overprescribing of students coming out of the Leaving Cert who actually want to undertake nursing, which is helpful. And paediatric nursing has the highest points in the whole of the nursing system. Some of it, it's really high points, and we are overprescribed. What we've managed to do is demonstrate that we've increased the undergraduate places for paediatric nursing by 10 places, which is good. So we've 10 more every year cumulatively going through since 2 years ago. Part of our supply is to look at increasing that again, and that's part of our plan that we're talking about on the supply and demand of nursing. We also have assessed and discussed with the nurses that graduate, and yes, we do, vast majority of them, like up to 90% of them, actually we offer a contract and they accept it on graduation, and we'll be doing that again. And we have to work very creatively within the current system that is very strong on headcount and budget to try and address that when we have 90 graduates coming out in September to December of next year. And we know we need them because we're in expansion mode, and how to do that. So that's a challenge that we're trying to work through at the moment. We know with our, when we evaluate our existing nurses, that the postgraduate nurses, those that are maybe qualify in general and then go and do a postgraduate course in paediatrics, they actually have done a bit of general and then come back and really want to go into paediatrics, and they stay kind of longer with us, and those courses don't take as long. So in our plan to the supply, we're looking at upping and can we increase the postgraduate courses. Now that does require funding investment, because those nurses are not full-time on your pay. They're 0.5, which means that somebody else has to pay for the other 0.5. So that's part of that plan that we've identified to see how can we actually increase them. And I think the accommodation, we definitely are, we have leaving interviews when people are actually leaving the services, and some of them are travelling long distance, and it just becomes too hard to actually continue doing that from a long-term perspective. So key worker accommodation is something that we want to focus on.
and that is the cost of accommodation is an absolute challenge, and I know that, but do you have a target? I mean,
we absolutely do. We have
a numbered target.
Yes, we do.
Okay.
So
if you maybe just even by year to give us the sort of how it's going to be phased in and how many will be expected. Like if you have a plan that there is a young man or a young woman in the middle of their Leaving Cert, or just finished their Leaving Cert now, and your hope is that they will in 4 years' time walk through the doors. How many of those have you identified? How many will you need? How many are going to come from existing resources?
So we've identified we want to up again by another 10 places in the undergraduate programme. So that's 10 every year, and then we want to add to the postgraduate programme, because there's only so much coming in every year. That's that the real leverage is in the postgraduates, because we're taking from all of the nurses that graduate in adult services to try and do that. So that's what we've identified. And then we have looking at the mix between healthcare assistant and nurses, and what can we contemporise that. That's something that we're looking at as well. With the unions involved, we sit down. We're doing this in a very collaborative way. It's not behind anybody's backs. It's done with, can we do things differently? So that's one of the things, so that we don't have that huge dependency in nursing. We're also quite willing to look at ways where nurses are used, which are new ways of working, like physician assistants that we see are introduced in some of the public system and the private system, and that to us is looking at using our nursing resources actually better. And we've identified then that there are elements of paediatric nursing where you don't need to be paediatrics, like theatres, because it's so we're looking at all of actually those elements, and that's all in this what we call the supply and demand of nursing that we've mapped out, and we have a process then with the HSE to identify, because some of these we need to go into the Department of Education and Skills and others to actually affect those changes.
Oh no, but my point is that should be done now. I mean, if those,
No,
if those people
we haven't
are,
done. I just want to be absolutely confident.
So you've
have done
targeted an additional 10 places.
Yes.
Okay. So in the intervening time between now and when the doors open, we're going to. So we've already established that there's not enough staff to open the urgent care centre from 8 a.m. to midnight, and that was what was promised. So that's not going to happen.
That's not nursing staff. That's a small number of consultant staff, which we are
But the
confident
net
we will be
effect
able
for
to
the people
agree.
in my constituency is the same. They're not going to have access to that
I totally
as was
appreciate
promised. It was promised 8 a.m. to midnight.
I totally appreciate that.
Okay, so the issue was not around building. The issue was not around the cost of building. The issue was around the staffing.
Yeah.
Okay, so that said, that is a fact. Doesn't matter what grade group or category of worker it is, there will not be enough workers to open it from 8 a.m. to midnight. That would be very disappointing news for people in Fingal who were promised that they would have it. Right, so that to one side. How then? And I don't for a moment dispute the fact that you are all working hard and making your absolute best efforts, and in no way is this intended to be critical of any one person.
Yeah.
But how then are we supposed to be convinced that you're going to have the staff for the hospital when you don't have the staff for the first small part of it? And I understand now that you're saying, well, it would be better to phase in. We weren't told it was going to be phased in. We were told it was going to be 8 a.m. to midnight, and that was the best. Now, since that can't be done, in fact, the best is something else, and it's wait, you'll have to wait, you'll have to wait. But how can we be convinced that the staff and plan, and I have to tell you straight up, I'm not convinced that there's going to be sufficient staff, and there isn't sufficient staff in the health service as it is, and there doesn't seem to be a targeted plan. So those kids who are doing or those young adults who are doing their leaving certificate now, have you identified those numbers, where they're going to fit, how you're going to cope with retirements and the inevitable maternity leave and the turnover and the churn of staff?
Yeah. So I can absolutely categorically say we have done what we're calling a supply and demand, which is workforce planning, what our requirements are for nursing, medics and health and social care professionals. We have set up a group with the HSE because the issues are broader than Children's Health Ireland to affect that. That group actually is established and is meeting. We now have a work plan mapped out about how to actually progress with that. Nursing been a bit ahead of the others because it's a bigger number. It's bigger the challenge, and the others with the doctors training youth. So we have identified what the requirements are, and we then within Children's Health Ireland are looking at how do we get the clinical placements? We're doing all of that planning. The directors of nursing are working actively on that. We also are doing what we're calling healthcare in a box. This is an initiative whereby we are gone out to Dublin 8 to the primary schools with initiatives to educate the primary schools, because it's not the leaving cert when they make this decision about where they want to go. So we have gone out to many of the primary schools in Dublin 8 trying to actually inform about what it is like working in a hospital, and we have taken this, I don't know if you've seen it from the STEM when they put engineering in a box, which our colleagues did from the development board. So we've replicated that, and we have got doctors, nurses, health and social care professionals gone out into the schools. It was only yesterday the Canal Way Educate Together kids came back into the hospital, whereby, or into our offices, and we awarded them some nice certificates of their understanding of where their future roles could be. So we do actually agree that we have a broader remit than just looking at what's coming out of the end of the universities. We actually within would believe that we have to work with the primary school and education system. And what we have pulled together with the development board actually is a community benefits group that actually has got the education boards, authorities actually in the local area of Dublin 12 and Dublin 8. We've actually got TUSLA, we've got the Guards, we've got HSE, and we've got and the Dublin City Council working with us to see how can we leverage this investment in an area that has a social deprivation to actually so that the whole of the area would benefit from that. And we see the opportunities there will be in the hospital as huge opportunities for unemployment. And the Development Board have been very successful in implementing employment for where there hasn't been employment in the past, and actually ensuring that I think we spent. Yes, so we've actually built in contracts for that, and we want them to build and see where the future roles are, so that we are people who are coming from the local community.
It's an area where it's actually where I'm from. I was actually born in St James's Hospital, so it's all my family live around there, so I would be well aware. There's plenty of teachers in my family as well, so I'd be well aware of what's happening with that. But really, if the supply and demand model and the workforce planning model that you're using to staff the hospital is the same as the one you're using to staff the urgent care centre, well then you'll forgive me for being a little bit sceptical, because the urgent care centre is not going to be staffed the way we were told. But look, hopefully, and I do welcome that work and the initiatives in the schools, and it is very good. Can I just ask one more very brief question? The separate entrance or part of whatever, the private healthcare facility that is being built, for which we will, I'm sure, pay handsomely at some point. Is that the direct result of the contract signed between consultants and Mary Harney? Is that the requirement? Because you did allude to the consultants having the facility of private rooms.
Is it the 2008 contract? Yes. I think it is the 2008, whoever was.
Well, it was Mary Harney, and it was the Fianna Fáil government at the time. That's granted. No, I just needed to double check that. Okay, that's
Thank you, Deputy.
Just referring to Deputy O'Reilly's questions before we go to Deputy O'Connell. I mean, there are many magnet hospitals around the world: Mayo Clinic, Johns Hopkins, Great Ormond Street, Toronto Children's. I presume that the National Children's Hospital will be promoting itself as a magnet hospital, where instead of having to go out and actually look for people, you will be receiving applications unsolicited, hopefully, to work in what will be a state-of-the-art hospital.
Absolutely, and already we're finding that we're being asked to support and give advice and guidance globally on our plans. And what our colleagues internationally are very impressed with is it's a national model of care, that we're looking at it as a network, that we're focusing very much on care as local as possible, that we are actually consolidating into one hospital. That's really helpful, that we're trilocating. And some of those plans they see is that they are envious of how they would like to do it internationally. And in their planning for paediatric health care, they're actually coming and seeking our advice and guidance, which is kind of not here we intend to do too much. But I do think that genuinely we have a plan, and it is going to be hard work. It is going to be challenging. But when we do it, and I believe we will, I think we'll be as good as anywhere in the world.
Okay, thank you.
Chair, I mean, there's been a huge focus on this project, necessarily so, on the capital project. I mean, over the last number of years, post the planning failure in the Mater and so on. But some of what Eilish and Emma have articulated today around the national paediatric model of care, which will radically transform paediatric health care in this country, and using the capital, the wonderful capital project as a lever to drive that reform. And I think that is what will attract the kind of excellence and the consultants from abroad, that opportunity to be part of that model of care and to truly drive better outcomes and experiences for patients in this country. And that's some of what we'd like to, I suppose, better articulate and communicate in this forum and elsewhere, and to use other opportunities, I suppose, to talk, as Emma spoke about so fluently there, about the wonderful opportunity that this hospital and that this model of care presents.
Thank you. Now, Deputy O'Connell.
Thank you. Just following on there from a couple of questioners on the private element of the hospital. So it's 9 beds off a concourse, so it's just 9 rooms, sorry. 9 rooms, sorry, 9 outpatient rooms.
There's no inpatient.
So I'd imagine this is a bit like a hangar at an airport, where you've wings off it. Is that the sort of thing? So you can add bits on. You were saying about being flexible.
Yeah.
So there's an entrance to each of these.
Yeah. So each suite of outpatients is off the concourse, and if they're built that way to be flexible, because we don't know in 20 years' time what the specialty requirements are. So you can flex the services up and down the suites, and one of them happens to be where the private outpatient.
Yeah. How many suites are there?
There's 119 rooms in total. I'll just have to try it.
There's 9 rooms.
There's just 9
in
rooms
this suite.
in this one suite.
So how many suites are there?
I'm
just really trying to get at what proportion of, is it 10%?
I think about 10 suites, about that. I can come back with the specifics. But
yeah, and are they all, is each suite 9 rooms? Is it?
Yes, they tend to be in clusters. Now, some of them are designed because of the requirements or a bit differently. So, for example, cochlear implants have some, huge requirements.
Rooms.
Yeah, for that. So and others have unique requirements. But again, the hospital has to be flexible as a building, so we've kind of managed them that way where you can flex them up and down.
You don't have a suite with 50 rooms and one with 5 rooms? No. And then, so this will be rented out, is it? Or how?
Yeah.
So in terms of Deputy O'Reilly's question about the contract, my understanding was there wasn't too many people in paediatrics on a dual contract. Maybe I'm wrong. What's the proportion of paediatric consultants on a public-private contract?
No, we don't have many, to be quite honest. And to be honest, private
ophthalmics and things.
Private healthcare isn't a big feature in paediatrics. Yeah. Yes.
So what's the? I suppose why? Why are we considering this? Why are we? I suppose my point is, why are we facilitating it?
Yeah.
So if there's, in my own experience, there's very little private input into children's care. Sometimes you'd have insurance companies claiming fees for neonates going into intensive cares and that. Sometimes they'll be charging extra fees, anaesthesis fees and that. But in terms of jumping the list as a child, my understanding was that, I don't go back over what Deputy Donnelly was saying, but that really there's not much of it. So I'm wondering, why ever was it considered to put in a suite, give or take 10% of the wing, for something that's not a big portion?
Yeah, well, I think it's because we're contractually obliged as an employer under the consultant's contract for them to be able to see private children in their facilities on the campus.
This is a hangover from the co-location in terms of the contract.
It's the consultant's contract. 2008 consultants contract.
Part of the national contract for consultants negotiations
so
in 2008.
Who services this suite? Is it, so when the cleaners are in, is it a case of this suite is totally paid for and then people rent it out and pay a fee?
Correct. We'll pay, and that's where I was saying earlier, we're going to work out what that, because we do have those facilities already in our children's hospitals, and there will be a fee paid for actually utilising, which will cover all of the operational costs and the costs of utilisation.
And will it be individual with the consultants providing the service, or will there be some external private company? Just for example, so you've got 9 rooms in a suite, you have 5 doctors, you have 10 doctors when you want to use them. Is it a company, or is it through the doctors individually, the consultants individually, the arrangement is made? Really what I'm getting at is I don't want to see the potential for a private company to control a part in terms of leasing. Because in private hospitals, the way doctors pay a whack of money to own a suite, I'm just making sure that that's not a possibility.
Yeah. So the current model we have is that the consultants actually pay a fee for actually utilising it, and it's run themselves. We don't have an external companies running them in the existing hospitals. We're reviewing that at the moment. I don't know if you missed that earlier. So we're actually looking at that and mapping out what it's going to be. But our intention is that the operating model is that if you use it, you pay a fee for it, and it'll be the individual consultant.
Okay. That's fine. Does Great Ormond Street have a private facility? It does as well.
It does, yes.
Okay. So it's not abnormal in the international way to have it like this. And if, I suppose, the policy changes,
yes,
obviously this can revert back into, no one's going to have a hold on a piece of the hospital. Yeah, no, because the hospital is, as I said, designed to be flexible, and there is no differentiating factor. If anything, the hospital is designed all single rooms, parents can stay in their rooms, meals delivered to rooms. It is the standard that should be in the public system. Yeah. Just finally, because I've said so many meetings on this, and I think most things have been exhausted, but I do think it's, I suppose, important to reiterate what Dr. Curtis said in terms of your role in delivering a hospital and the positives. And I've said it here many times, and I know Dr. Harty and I know my colleagues are perhaps aware of, and you're definitely aware of, the state of Temple Street, the state of Crumlin. And that I remember 9 years ago, prefabricated theatres being craned into Crumlin. I was in the car park of it, and I thought to myself, what a waste of money. There's a new hospital being built. So those units have been, these prefabs, and I'm sure they're servicing children as well as they can, are now 9 years in existence, and we're still, that's the facilities we're giving our children. And I do acknowledge that it must be very difficult in terms of the negativity around this. And I know Dr. Curtis referenced that, you did a very good job in planning and designing. But our job as public reps is to try and get value for money. And I have never had a problem with the location when I studied it. I've never had a problem with providing the best of care for our children, long overdue. I'm a very, very big supporter of the tri-location and would like to see a master plan delivered for the site in terms of planning. I understand the money in the National Development Plan isn't there, and I understand the cascade of priority and when it comes to the National Maternity Hospital being first on the list. But I do think for people who are looking at it and who are losing the will to support the project at times, many people have supported from a tri-location model, but also to be the best provider of healthcare. But our job in here, and the public anger, to my mind, has been about the money element, and that it's just so much money, and we have to take money from elsewhere to pay for it. And yes, it'll be a fantastic hospital, but that's our job, and it's not a personal criticism. We put ourselves in the public eye and take what we're given most of the time, and much of it deserved. And I do think many of you have received undue public criticism, but that said, that's just the way it goes. And I suppose I will support you in anything I can do in this challenging job to deliver, but it would make many of us sleep a bit easier at night if we could see a maternity hospital happening in the near future, whenever we have a few pounds spent on another hospital in the next plan. So thank you all for your work and your time this morning again.
Thank you very much, Deputy O'Connell. Deputy Durkan, we'll give you the final word. If you have any words.
It is the final word, Chairman. I would have I apologise to my colleague whom I lampooned when he was unavoidably absent. Likewise, I apologise for my absence during his outburst as well. But on the next occasion,
I think you should carry on.
On the next occasion, I can assure you that I will give full time and attention to the necessary response.
I gave you both leeway. I think the next time you should have your conversation outside the chamber.
This is a dispute.
No, these things that happen in the chamber. Whatever happens in the chamber is accountable in the chamber. Don't worry about that.
Thank you very much, Deputy Durkan. So that completes our meeting this morning. So on behalf of the committee, I'd like to thank you for coming. Sorry, the clerk is reminding me that you have invited us to visit Connolly, and we're very happy to take up that invitation. So we hope to go there in July, either the 3rd or the 10th of July. We'll have to pick an evening, so much. Probably a Wednesday afternoon.
Perfect.
But we'll decide.
We're happy to accommodate.
And we'll give you sufficient notice.
Thank you, Chair.
So on behalf of the committee then, I'd like to thank the various representatives, Mr Barry, of course, and Dr Emma Curtis from the National Paediatric Hospital Development Board, yourself, Eilish Hardiman, and Professor James Brown from Children's Health Ireland, Tracy Conroy and Colm Desmond from the department and from the HSE, even though you didn't get an opportunity to make a contribution, Dean Sullivan and Jim Curran. Thank you very much. This meeting is now adjourned until 12:30, when we are going to hear from the department in relation to the legislation underpinning the tribunal on cervical smears. Thank you.